nor there is any diabetes, hypertension, asthma, or thyroid disorder in the family. Coming to the summary of the case from the history, we come to know this is a 24-year-old girl who is experiencing breathlessness and palpitations and chest pain since 10 years, all of which have increased since the past 1 month. And she is currently on oral medications, mostly for rheumatic heart disease prophylaxis. On physical examination, I examined the patient in adequate light and exposure after taking a consent in presence of a female attendant. The patient is conscious, cooperative, and well-oriented to time, place, and person. She is averagely built and moderately nourished with a BMI of 22. Coming on the vitals, she is currently afebrile. The pulse rate is 96 beats per minute in the right radial artery in supine position with normal force, volume, tension, character, with no radioradial or radiofemoral delay. The blood pressure is 130/80 millimeters of mercury in the right brachial artery. The respiratory rate is 18 cycles per minute. The JVP is normal and there is no apex pulse deficit. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. The skull, skin, spine is normal. Coming to the systemic examination, on cardiovascular examination, on inspection, the shape of the chest is elliptical. It is bilaterally symmetrical. The precordium looks normal. The apical impulse can be seen on the left mid-clavicular line about 4 centimeters below the nipple. There are no other precordial impulses seen, no epigastric pulsations or any suprachoroidal pulsations. The skin is normal, no scars, sinusoidally dilated veins, and the rest of the chest is normal. Coming to the palpation, the inspected findings were confirmed. A tapping apex beat can be felt in the left 6th intercostal space in the mid-clavicular line. Diastolic shock is also present. However, there is no parasternal heave or epigastric pulsations, and no thrills could be felt. Coming on to percussion, the left heart border can be percussed, so it slants downward from the 2nd intercostal space till the apex, and the right heart border is extending 1 centimeter laterally to the sternum. On auscultation, the loud S1 can be heard in the mitral area, S2 is heard in the pulmonary area, and a mid-diastolic rumbling murmur is heard in the mitral area of grade 3/4, of grade 3, with mild radiation to the axilla. Coming to other systems examination, on the respiratory system, the air entry is bilaterally equal with no adventitious sounds heard. Per abdomen is soft and non-tender. And on central nervous system examination, no focal neurological deficit is present. Coming to the summary, this is a 24-year-old girl presenting with breathlessness, palpitations, and chest pain since 10 years, all of which have increased since 1 month, and is on daily oral medications, mostly for rheumatic heart disease prophylaxis. On examination, there is no raised JVP nor any tachycardia, but the apex is shifted down and out, which is of tapping nature. And on auscultation, there is a loud S1 with a normal S2 heard with a mid-diastolic murmur, which is mildly radiating to the axilla. So most probably, this suggests a valvular heart disease. Coming to the diagnosis, this is a case of mitral stenosis with mild mitral regurgitation due to underlying rheumatic heart disease, along with pulmonary hypertension and atrial fibrillation. However, she is currently in sinus rhythm without any signs of infective endocarditis. Thank you, sir.
Hello.
Yes,
Mr. Kunj, you are done with your case?
Yes, sir.
Yeah. Why do you think it is a case of mitral stenosis?
So first of all, since the patient is coming with a long history of breathlessness and palpitations, so this goes in favor of a cardiovascular origin. And since
I'm just asking, why did you think that it is a mitral? Because you have presented the history as well as the examination findings.
Yes, sir.
What are the points favoring mitral stenosis? Simple, straightforward.
Yes, sir. So on examination, there is palpable P2 present, so it goes in for pulmonary hypertension. Then also the right heart border on percussion is slightly towards the right side. The laterally can be percussed 1 centimeter laterally, so suggestive of right ventricular hypertrophy. And
no, hope my question is very clear. what points made you to think that your case is has got mitral stenosis?
So on auscultation, a mid-diastolic murmur can be heard, which is of rumbling quality in the mitral area. So that goes in favor of mitral stenosis. One of the differential diagnoses of mid-diastolic.
Okay. Okay. And what made you to think that it is mitral regurgitation as well?
Sorry, sir.
What made you to add the diagnosis of mitral regurgitation as well? Mitral stenosis, I do agree. Loud S1 was there and mid-diastolic rumble or mid-diastolic murmur was there.
Yes,
as
sir.
per your presentation. In a patient with a breathless patient, prolonged exertion, breathless patient. I do agree.
Yes.
Without PND, all those things are fine.
Yeah, sir.
What points made you to bring in the diagnosis of mitral regurgitation?
So because on inspection and on palpation, I could palpate the apical impulse. It was down and out, not in the usual location of middle to mid-clavicular line. So if this would be a case of pure mitral stenosis, there won't be any shifting of the apex because there won't be any eccentric hypertrophy of the left ventricle. But however, because of mitral regurgitation, there could be eccentric left ventricular hypertrophy, which could have caused the.
Do you think that mild mitral regurgitation produce ventriculomegaly?
Not much, sir, but here in this case, since the mitral stenosis could be a predominant feature, so along with that, right ventricular hypertrophy may have caused the shifting of the apex towards the outside, and mild regurgitation may have caused it to go shifted downwards. So that a combination effect of both the.
And in history, you also suggested some blackout. What was the reason for the blackout? What did you mean by blackout?
So blackout means she had a acute entire vision. There was an entire blackening of the vision in front of her. Like she suddenly collapsed in front of in the house only. But
so you mean to say that she had syncope? Was it a syncopal attack?
Yes, sir. For a short amount.
What are the cardiovascular causes of syncope?
So it can be atrial fibrillation, or suddenly it embolization from the atrial appendage going to the vertebrovascular artery. That could be the main two reasons in this condition. Because of chronic mitral stenosis may have
in
caused.
A valvular heart disease, in a rheumatic valvular heart disease, what are the causes of exertional syncope?
Exertional syncope.
Patient develops exertion graying of vision or exertion syncope.
So, pulmonary hypertension can cause this.
Okay. Dr. Archit, please.
What will be the auscultatory finding in mitral regurgitation?
Mitral regurgitation.
What murmur you get? Mitral regurgitation. You said there's the murmur which goes to axilla. Which is the murmur which usually goes to axilla? Is it the mid-diastolic?
No, sir, it will be a early diastolic murmur.
Diastolic murmurs are very soft. They generally don't go anywhere. If you're auscultating something in the axilla, radiating, which is that murmur? Mitral regurgitation produces?
1 second, sir. Carry.
What's the type of murmur? Is it? It's not a diastolic. So what should be the murmur?
Systolic murmur.
What type of systolic murmur you get in mitral regurgitation?
Ejection systolic murmur, sir.
It's pansystolic.
Sorry, pansystolic. Yes.
That's the murmur which goes to the axilla. Here in the final diagnosis you have written there is atrial fibrillation currently in sinus rhythm. How do you know this patient is in atrial fibrillation?
So because she had intermittently episodes of palpitations on and off, so that goes in favor of atrial fibrillation. But currently on examining the pulse, it is normal.
Pulse was regular, but she had history of palpitation. So you think this is atrial fibrillation that is there?
Yes.
Fine.
You said second heart sound is also normal, and now the.
Yes, I could not appreciate any abnormality in the auscultation of second heart.
If you did not appreciate in the examination, why did you bring in the diagnosis of pulmonary hypertension again?
Mm. So because on percussion, on the right heart,
What are the findings of the pulmonary hypertension?
so because second heart sound was palpable in the left second intercostal space. So diastolic shock is a sole, like one of the main signs for
You said
pulmonary.
in intensity on auscultation. Okay, did you mention about her marriage and menstrual cycle or pregnancy, something like that in history? I don't.
No, sir. Actually, she's a 24-year-old girl and she has a normal
Any
menstruation.
relevance to the valvular heart disease? No, she is 26-year-old, 26 or almost 26-year-old. Is she married?
No, sir, not yet, sir.
So did you mention that? Marital history, pregnancy. What is the relevance of history of pregnancy in valvular disease?
So in valvular heart disease, we usually don't, we counsel her for not getting married because pregnancy would be a, depending on severity, we ask her not to get, get married, but not to get pregnant because the pregnancy is a condition of high cardiac output state. So there are more chances of going into failure immediately postpartum or in the third trimester of pregnancy.
Okay. Among the valvular heart disease, which valvular disease will not get complicated during pregnancy? Okay, doesn't matter.
No, sorry, sir.
I think you should. How do you work up the case further? What are the investigations required to confirm your diagnosis?
So to confirm the diagnosis, I would first like to do a ECG for seeing the atrial fibrillations or any signs of pulmonary hypertension. Then further, I will go for a chest X-ray to see for the straightening of the left side of left heart border. Then also going for a 2D echocardiography for
what are the X-ray findings in mitral stenosis?
So in mitral stenosis, there will be a straightening of the left heart border because of the pulmonary hypertension and the left auricular appendage gets enlarged.
What else?
Any other findings?
What else will be there in X-ray?
Because of the left atrial hypertension, there will be a doubling of the border of the right side border will be doubled because of left atrial hypertrophy.
Okay. You call it as shadow through shadow. Okay.
Yes.
Anything else? Any other?
Any other structures will become prominent other than the atria and the pulmonary artery?
The apex may get maybe from.
Right. Okay. Do the confirmatory by echocardiography?
Yes, sir.
Echocardiography. So what will you look for in the echocardiography specifically, other than what you have made out clinically?
So I would like to look for the mitral valve area, how much it is.
Okay, mitral valve area, correct.
Grading the stenosis.
Correct.
Then for seeing for the amount of regurgitation if it is present.
Fine.
And also to see for other valves like tricuspid and the aortic valve if there's any associated stenosis regurgitation.
Other than valves, anything else you look for which we will not be able to make out clinically, which is a very important complication. You can see something inside the heart.
So,
inside the heart.
The papillary muscles.
No, you were talking about some syncope, atrial fibrillation causing something.
Yes, sir. For any left atrial thrombosis causing thrombosis, which can lead to syncope.
Look for that.
Yes, sir.
Okay, what is the ideal management at this stage? Of patient going to such an extent that she has got severe breathlessness, not able to do her day-to-day activity, stage 4 breathlessness, class 4 breathlessness.
So I would advise her to go for a interventional cardiology. I would advise her to go for mitral valve replacement.
Replacement for mitral stenosis.
So, but here, since along with mitral stenosis, there's a mild component of mitral regurgitation.
No, it's only mild, no? If at all, it is mild, as per you. So, what is the treatment of choice in a moderate, severe mitral stenosis?
So, if it is,
I'll also tell you that valve is not calcified, non-calcific valve.
Yes, in this case, like if it's a purely mitral stenosis, I would go for balloon mitral valvulotomy. But since on echocardiography, if I get a regurgitant lesion, then that would accentuate if I go for valvulotomy. So I would go for a mitral valve replacement in that case.
Okay. Does this patient require a anticoagulation therapy, oral anticoagulation therapy?
Yes, sir. Depending on the material of mitral valve replacement, we'll have to advise her. So if it is metallic, then I would advise her for anticoagulation of warfarin. But if it is bioprosthetic, then the anticoagulation may not be required.
Even without procedure, before procedure, now does the patient require?
Yes, sir, even now, because of atrial fibrillation, the patient can go into thrombosis. So thromboembolism phenomenon can happen. So I will keep the anticoagulants.
What is Chadwa score?
So that is a score for the anticoagulation therapy to be given in cases of fibrillation, to decide if you want to give a single antiplatelet or a dual antiplatelet therapy.
Platelet or anticoagulants? You give warfarin, or you want to give newer anticoagulants for this patient?
So I will give a newer anticoagulants.
Anticoagulants have not been proven. For rheumatic heart disease, newer anticoagulants have not been proven. So only for other conditions it's been used. For rheumatic, still we are giving warfarin as the treatment of choice. How will you monitor the patient who is on warfarin?
So I would monitor the PT-INR, which should be kept between 2.5 to 3.5 values.
Sir, shall we?
Yes, sir.
Yeah, Ms. Achaya is a fourth-year student from Madurai Medical College, Tamil Nadu. Can you please share the presentation?
Case.
Go ahead.
A 61 years old male patient, Mr. Tangappan, who is a furniture shopkeeper by occupation. His informant is his son, who is reliable. The patient came with chief complaints of history of inability to move right upper limb and lower limb since 5 days, history of deviation of angle of mouth to left side for 5 days, history of difficulty in speech since 4 days. History of presenting illness. Before 5 days, patient is apparently normal. Then, on the day of event, around 10 a.m., patient was going in bike with his son. After 1.5 hours of getting up in bike, when patient tried to get down from the bike, he could not stand without support. And then he could not walk without support, as he developed weakness in right lower limb. After 2 hours, patient came to hospital. He walked with support and got admitted. After 4 hours, the weakness gradually progressed and patient could not even move his right lower limb. Around 8 p.m., patient could not move his right upper limb also. Patient developed slurring of speech on the same day, and after 2 days, he could not speak itself and could not understand the commands given by his son and doctors. History of weakness in right upper limb and lower limb, insidious in onset, gradually progressive, attained maximum weakness of upper limb and lower limb on the same day, and inability to speak after 2 days. Weakness in right upper limb started before right lower limb. Patient had similar episode 2 months back with blurring of vision and slurring of speech, which resolved spontaneously onset with no residual deficit. After which, the patient was put on clopidogrel prophylaxis. Patient developed hematemesis. Endoscopy was done 10 days back, after which he was advised to stop taking clopidogrel. After 5 days of stopping clopidogrel, patient developed weakness. Patient is a known hypertensive for 3 years and is irregularly taking medications. Patient is also diabetic for 3 years. History is suggestive of flaccid type of weakness of right upper limb and lower limb. Patient has difficulty in combing hair, buttoning and unbuttoning shirt, getting up from squatting position, difficulty in grasping slippers, difficulty in rolling over and getting up from bed. Patient has no difficulty in holding neck above pillow. No history of involuntary movements. No history of sensory disturbance as told by attender. No history of bowel or bladder disturbances. No history of loss of smell sensations. No history of visual disturbances. No history of double vision or difficulty in eye movements. No history of difficulty in chewing or loss of sensations over face. Patient had history of drooling of saliva and deviation of angle of mouth to left side. No history of hard of hearing. No history of nasal regurgitation. No history of difficulty in tongue movements. Patient had no history of fever, no history of headache, nausea, vomiting, seizures, or loss of consciousness before the episode, no history of trauma, no history of memory or behavioral disturbances, no history of chest pain, palpitation, no history of cough with expectoration or hemoptysis, no history of giddiness, no history of urinary incontinence or constipation, no history of loss of weight or loss of appetite, no history of multiple joint pain or swelling over limbs, no history of abdominal pain, swelling or jaundice. Past history, as I told before, the patient had similar episode 2 months back and he was put on clopidogrel, and 10 days before he got hematemesis, after which he was recommended to stop taking clopidogrel. After 5 days of stopping clopidogrel, he got this episode. Patient is not a known case of TB, HIV, epilepsy, COPD or any other chronic illnesses. Family history, no history of illness in family members. Personal history, patient is a smoker for 10 years and alcoholic for 10 years. He takes alcohol weekly once. General examination, patient is conscious, moderately built, afebrile, no pallor, icterus, cyanosis, clubbing, lymphadenopathy, pedal edema, no neurocutaneous markers were seen, no signs of atherosclerosis were seen. Vitals, pulse, 78 per minute, regular in rhythm, normal in volume and character, felt in all peripheral vessels, no radioradial and radiofemoral delay, condition of vessel wall was normal. Blood pressure, systolic 130, diastolic 80 mm of Hg in left upper limb, measured in sitting position, respiratory rate 20 breaths per minute, temperature was 98 degrees Fahrenheit. Central nervous system examination, higher functions, patient was conscious, orientation, memory, intelligence, handedness could not be tested because the patient was in global aphasia. There was loss of motor speech and comprehension was also lost. Cranial nerve examination, only cranial nerve, for cranial nerve 7, facial asymmetry is seen, deviation of angle of mouth to left side is seen. Other cranial nerves could not be assessed because the patient was in global aphasia. Spinomotor examination, no muscle wasting is seen. Tone, right upper limb and lower limb hypotonia, left upper limb and left lower limb normal. Power could not be assessed. Reflexes, right side, conjunctival reflex present, corneal reflex not done, abdominal reflex absent, cremastic reflex is not done as attender did not give consent. Plantar reflex, plantar extensor, deep tendon reflexes, biceps jerk exaggerated, tricep jerk exaggerated, knee jerk exaggerated, ankle jerk exaggerated. Left side, all the reflexes are present. Plantar reflexes flexor. Abnormal movements are not seen. Sensory system examination could not be done. Cerebellar function test, due to motor weakness, these tests could not be done. Examination of autonomic nervous system, normal. Spine and cranium examination, no bruit or deformity, no peripheral nerve thickenings. Other system examination, cardiovascular system, first heart sound and second heart sound heard, no murmurs. Respiratory system, normal vesicular breath sounds heard. Abdomen, soft, no distension, no organomegaly was seen. Diagnosis, a case of completed stroke with right-sided hemiplegia, with left-sided upper motor neuron facial palsy, with global aphasia, involving left internal capsule with middle cerebral artery occlusion due to thrombosis, probable etiology being atherosclerosis.
Why do you say it's a cerebrovascular accident? As you said, it's insidious in onset.
Yes, sir.
Insidious in onset. Usually, what is the onset when we say cerebrovascular accident?
Sudden.
At least the beginning was sudden. You should have said that beginning was sudden and later the progression was insidious. You said that.
Yes.
Okay. So you think this is a cerebrovascular accident, which is thrombosis involving the middle cerebral artery internal capsule. So which feature is not fitting into internal capsule? Which of the features your patient is having is not fitting into internal capsule?
Dense hemiplegia should be there in internal capsulation.
Okay. What else which is there in your patient which is not seen with the internal capsule?
Global aphasia is not seen.
The aphasia. Aphasia, where is the site of lesion?
Stem of middle cerebral artery occlusion causes global aphasia.
Correct. Where is the
The
site?
lesion should be in cortex, dominant cortex should be involved.
Dominant cortex. So dominant cortex should be involved. So with the aphasia that is there, you can't say it as internal capsule lesion. Okay. That is something. So you can say that middle cerebral artery territory, and as you said, global aphasia is there, so you can say it is that much. But with the aphasia is very dominant, the lesion has to be in the cortex. That is what you have to remember there.
Okay, sir.
I heard you saying that patient has got right-sided hemiplegia. Was it right-sided hemiplegia or left-sided hemiplegia?
Right-sided.
Right.
And you said left-sided facial palsy.
Sir, angle of mouth deviated to left side.
No. Your final impression was left-sided facial palsy. Please show that slide again.
Yes, sir.
Okay, if it takes time, doesn't matter. But if you meant that the facial palsy and hemiplegia is on the same side or different sides? Because your slide
Sir,
appears
same,
that. Show me your last slide.
lesion is on left side.
I just
Okay,
wanted to
sir.
confirm again. So anyway, what is cross hemiplegia?
If there is ipsilateral cranial nerve involvement and contralateral hemiplegia, mostly in brainstem lesions, it is called.
Okay, now what did you write here? With the global aphasia.
Left-sided.
See, you have written right-sided hemiplegia with left-sided human facial palsy.
Yes, sir.
You written crossed here.
But in the cross hemiplegia, you will get UMN.
No, sir. LMN.
So there
is something wrong.
Yeah.
Okay, sir.
Correct it as right-sided facial palsy.
Okay.
Oh, okay, sir.
One more contradictory statement I found is patient. You said the patient had significant hypotonia.
Yes, sir.
But on the contrary, you said all the reflexes were brisk. What is the reason for that? Hypotonia and brisk reflex. Does it go hand in hand?
No, sir. No, sir. Usually, neurogenic shock patient is in hypotonia, but reflexes are not much.
No, that's what I'm asking you. In neurogenic shock, even reflexes will go for, will be absent or markedly diminished. You have told that hypotonia and, okay, anyway, it's okay, doesn't matter. So, but if you're explaining it as neurogenic shock, the reflexes, dependent reflexes cannot be explained as a brisk, okay?
Okay, sir.
Fine. Did you look for any specific,
You said the power you could not assess, why is that?
Sir, when we told to raise the hand, the patient could not raise. Patient did not do what we asked to do.
Okay, but any other way you can make out whether the hand is moving, whether it is 0 by 5 power at least?
Yes, sir. It's mostly 0 by 5 power, sir. No movements were seen.
Yeah, that's what. When you give a painful stimulus or something, you can make out whether it is 0 or not.
Yes, sir.
That has to be told. You can't say that you could not make out the power.
Okay, sir.
any significant, in a case of any CVA for that matter, any significant vascular finding did you look for? You have told about pulse volume, all those things. But I think you're not mentioned one significant vascular finding. You mentioned murmur, regularity, all those things, fine. Did you mention about carotid thrill or carotid bruit? Did you look for that?
No, sir.
Okay, fine. You have to mention about that. Every CVA case, you should mention about whether present or absent has to be mentioned in the examination. Okay, anyway, it's not a teaching session. Anyway. Okay. So what investigation would like? Yeah, please.
Risk factors? What risk factors this patient has?
This patient had non-modifiable risk factor. His age is more than 60 and he's a male. Modifiable risk factors like he's a hypertensive, diabetic, and he takes alcohol. He's also a smoker.
Fine. Okay. Evaluation. How will you investigate him?
This patient came less than in 3.5 hours. So immediate non-contrast CT brain should be done with blood glucose levels. If no hemorrhage is found, then thrombolysis can be done.
You think this patient is a candidate for thrombolysis?
No, sir.
Why?
Because thrombotic strokes or stroke in evolution
No.
He came to hospital within 3.5 hours, but it takes time to do CT and other things.
That's okay. Even if everything is done within 3 hours and everything is ready, can you thrombolize this patient?
In the background of some significant history you had given.
He had hematemesis recently 10 days back, so
that is a contraindication. Contraindication.
Okay,
so what are the other tests you want to do? Other blood investigations, other than
blood investigations like complete blood count, bleeding time, clotting time, platelet count, and ESR should be measured. Blood glucose levels should be measured. And lipid profile should be done.
Lipid profile has to be done. What drugs you will put this patient on?
I'll put this patient on statins. Then he's a diabetic, so he should continue his medications. Antiplatelet drugs. I'm not sure if he can be put in antiplatelet drugs again.
Why?
He had an episode of hematemesis and he stopped taking clopidogrel.
If you don't put the antiplatelet drug, what will happen?
Again, he will get the attack.
Get an attack. So you'll have to try to do something other than antiplatelets. Anything else you can do? He said he got one TIA something 1 month back, and now
Yes,
again
sir.
he has got stroke there. So fast he's getting episodes.
Yes, sir.
So anything else?
Low dose aspirin. Low dose we can give antiplatelet drugs.
Those drugs are correct. Those drugs can be given if provided he doesn't develop a complication. Anything else you can do? Possibly that carotid is completely blocked. What can you do?
Carotid endarterectomy can be done.
You have to look for that. You will have to evaluate for that.
Okay, sir.
Get the investigations done for that and see if anything can be done.
Okay, sir.
Okay, now stroke is completed. What is how do you counsel, how do you advise other treatment, non-pharmacological therapy?
Physiotherapy, passive physiotherapy should be started even before the patient could move, and active physiotherapy should be started once the patient can move his limbs. Skin care should be given to prevent bed sores. The patient should be turned to opposite side frequently. Then bowel and bladder care should be given. Catheter is put and in a sterilized manner. Catheter should be put. Riles tube can be put to give orally food and all.
Okay. Fine. I think your time is up.
Okay.
Good.
Thank you, sir.
Achha, yeah.
Ms. Ritika is a 4th year student from MSRMC Medical College, Bangalore. All the best, Ritika. You can start the presentation.
Good afternoon, judges. My name is Ritika. I'm from Ramaya Medical College. So presenting a case of a 30-year-old male who's a farmer by occupation, hailing from Bagalkot, is a right-handed and educated till 10th grade. Presents with complaints of weakness in the proximal aspect of the left upper limb since the past 4 years. History of presenting illness, the patient was apparently normal until 4 years back, where he noticed weakness in the proximal aspect of the left upper limb, which was insidious in onset, gradually progressive up until 6 months ago, since when the weakness has become static and it is not associated with pain. He also gives history of difficulty in lifting heavy objects, reaching out for high objects, combing hair, lifting the left arm above the level of shoulder. No history of pain, muscle cramps, headache, neck pain, loss of consciousness. There's no history of numbness or sensory loss. There's no history of altered bowel or bladder functions. No history suggestive of cranial nerve deficits. No history of trauma. History of fever, which was preceding the onset of weakness or exposure to toxin or heavy metals. In the past history, there's no similar complaints in the past. He gives no history of poliomyelitis, diabetes mellitus, hypertension, epilepsy, tuberculosis. No history of previous hospital admission or surgeries. No allergies or significant drug history in the past. Under the family history, there's no similar complaints or nothing significant. Under the personal history is a predominant vegetarian by diet, sleep being undisturbed, appetite is normal, bowel and bladder is regular and normal. He's a non-alcoholic and non-smoker. At the end of this, I'd like to summarize a 30-year-old male presented with weakness in the proximal aspect of the left upper limb since the past 4 years, insidious in onset, has progressed up to 6 months and later has been static till date. It is not a known case of diabetic or there's no history of past polio in the childhood. General physical examination, young male, moderately built and nourished, cooperative and well-oriented to time, place, and person. Vitals being blood pressure, 130 by 80 mm of mercury in the right brachial artery, normal in rate, rhythm, and volume. The pulse is 82 beats per minute. Respiratory rate is 13 cycles per minute. Temperature afebrile. There is no noted pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Spine was normal. There was no noted spinal tenderness. Neurocutaneous markers, none noted. Under the systemic examination of central nervous system, the higher mental functions were normal and intact. Under the motor examination inspection, fasciculations in the left deltoid, no winging of scapula, decreased bulk in the left arm, thinning of the proximal aspect of the left upper limb compared to that on the right. So as noted, the right arm circumference being 29 centimeters as compared to left, which shows a decrement of 5 centimeter being noted. The decreased tone in the left arm compared to the right arm. So there's hypotonia noted in the left arm. The picture stating the left arm, the bulk, and there is thinning of the arm muscles, which we see on the left side as compared to the contour on the right side. Under the power being tested for individual muscles in the left upper limb, deltoid, biceps, triceps, supinator, rhomboids, latissimus, and small muscles of the hand, there was marked weakness which was noted in performing the actions of these muscles in the left upper limb when compared on the right side. So as the patient was being tested for abduction for understanding the muscle action of deltoid, we see on the right side compared to the left side, he has weakness of abduction, not even going beyond 20 degrees from the level of the body. Both the photos showing that there is decreased tone and decrease in power by the end of this. Reflexes on the left side, the biceps, triceps, supinator, though present, was diminished as compared to the right side. The lower limb reflexes on left and right were both normal. So at the end of this, marked atrophy, weakness in the proximal aspect of his left upper limb. The rest of the neurological examination was unremarkable. Sensory cranial nerve system was normal. Cardiovascular, S1, S2 heard, no added murmurs. Respiratory system, normal bilateral vesicular baseline, no added sounds. Per abdomen, no organomegaly noted. All the quadrants moved equally with respiration. So at the end of this, I would like to summarize that the 30-year-old male presented with complaints of weakness in the proximal aspect of the left upper limb since the past 4 years. Insidious in onset, progressed until 6 months and later has become static. He is not a case of diabetic or no polio in the past. On examination, he is a well-built, middle-aged man with reduced bulk, thinning of the proximal muscles, fasciculations in the left deltoid, reduced tone, power, diminished reflexes. The rest of the neurological examination was noted. Based on the history and the highlighted points, come to the provincial diagnosis of a lower motor neuron disease, probably a monomelic amyotrophy involving the proximal aspect. The differential diagnosis ruled out on the basis of history was multifocal motor neuropathy, spinal muscular atrophy, chronic focal myositis, brachial neuritis, and a late progression poliomyelitis. Before I end the presentation, I would like to add a little note about the significance of the case being discussed above. So this case being discussed above has a similar clinical course to what is referred to as the Hirayama disease, also called brachial monomelic amyotrophy, which is sporadic in nature, insidious onset, progression for 2 to 4, later becomes static, with unilateral distal upper limb weakness and wasting, and the rest of the neurological examination is intact and normal. So with individual points being noted, there's an isolated atrophy, weakness, fasciculation as noted in this above patient. And it's very similar to what is noted in the literature as Hirayama brachial monomelic amyotrophy. So the importance of this case being the patient being 30 years, the clinical course being very characteristic, the reduced tone, the reduced power, but the involvement of proximal as compared to distal in the traditional case of Hirayama. So the patient was further investigated because the clinical course was resembling Hirayama disease with motor nerve conduction studies, electroneuromyography, and an MRI cervical spine flexion, which is characteristic for Hirayama, but nothing as noted classically was noted in this particular patient. I would like to end the discussion by saying that the literature for this particular case in pathology and investigatory treatment being very less, And the noted pathogenesis for the same case being an imbalanced growth between the vertebral column and the cervical cord of the patient, causing compression against the vertebra. Microcirculatory changes leading to necrosis of anterior horn cells could be one of the possible pathogenesis for this particular case discussed above. And this is to end my presentation by saying that the amount of literature reported so far in our own country being very less, forecasting the importance of this case. Thank you.
Yeah, please go back to your history slide once. Don't shut down the slides because in between my thing. Okay. Now, it's a good case you have presented well. Now, what I want to highlight is that in history, did you mention anything about sensory symptoms? Did you mention history of sensory symptoms?
No numbness or sensory.
I'm not able to hear. Is it my connection?
Audible?
Hello, did you mention any sensory symptoms in the history? What sensory symptom in a patient who has got upper limb weakness, what sensory symptoms you will elicit during history, in the history?
So if there's any numbness or tingling sensation that the patient had, that was elicited from the patient. He says he gives no history of numbness, tingling sensation, or any dysthesias, any pin and needle tickling kind of sensation was elicited.
Okay. Any other specific type of history would like to, sensory deficit would like to elicit in a patient with a small area of the weakness or wasting or loss of power? Okay, fine. So this patient did not have any kind of numbness or sensory loss as per your statement. I missed that slide anyway. Okay. So your differential diagnosis was pure motor disease. Why not? Okay. What is dissociative sensory loss? Hello? Okay, I'm not able to hear. Archit, please.
Yeah, I think from her side only there is.
Ritika, we can't hear you.
Ritika?
Your internet is not stable actually. So I have switched off the video. Ritika, are you there?
Can you hear me?
Yeah, now.
Yeah, now it is audible.
Yeah.
Now,
Ritika,
before going to the such a, yeah.
Dissociative sensory loss. Yeah. That was what was sir asked. Last question was, what is dissociative sensory loss? Or which condition you will get it? There's some problem with that.
Ritika, we can't hear you. We can see you, but there is no audio. No. Yeah, now is we can hear you.
I'm not sure of dissociative sensory loss.
Okay. I think before going for the multiple diagnosis, different diagnosis like this complicated thing, you should tell us about the specific sensory histories, which should be highlighting what are the things when you get a one-sided motor weakness or one-sided thinning of the limbs. Did you mention anything about seasonal variation or diurnal variation of any motor weakness, muscle weakness? Because it's a long duration muscle weakness, isn't it? Which disease will be having seasonal, diurnal variation, or at least diurnal variation? Motor weakness. This symptom was a predominant motor weakness lasting for 6 months or 4 years.
4 years, yes.
Yeah. So in
which
such
is
a long
disease?
history of
which is a disease with that diurnal variation of motor weakness? Very common disease other than these rare diseases. Fatigability is a feature of which muscle disease? Can't hear you.
Okay.
Audible?
Yeah, you're audible.
Any myopathies which causes muscle fatigue?
No.
I'm not sure.
Okay, fine. Now, I think your right upper limb weakness or left upper limb weakness, proximal weakness, you need to talk specifically about something like sensory symptom, like not just the sensory loss, radicular pain or root pain has to be mentioned. Dissociative sensory loss has to be mentioned very, very specifically. Okay. And how do you differentiate it from a axillary neuropathy? No, axillary neuropathy also.
Any deep aching pain in the neck if he has brachial neuritis, to differentiate that.
Okay. Anything else? Any other thing?
I mentioned no.
Because he said it is not progressive, it is static. It was progressive only for 6 months, then it was static. If it were to be some muscle disease or myopathy or something else, which were progress, isn't it?
So, given the clinical course of the above mentioned condition, which is progressing for a specific amount of time and later becomes static, so thought of that as a differential based on the history.
Okay. Now, when you think of differential, you should know different causes, common things like axillary neuropathy or like brachial plexipathy. I think you have mentioned already.
Thought of spinal
cord should have been also considered.
Spinal muscular atrophy was
spinal muscular atrophy is a different thing. Spinal cord disease also should have been considered.
Compressive myelopathy was considered, sir, but he didn't have
compressive
any.
Myelopathy it should have, because
he didn't have any history of pain. He didn't have any urinary bowel discomfort or sensory.
In spinal cord, when you say compression, it need not compress everything. We just involve certain structures. This is a slowly progressive disease, a non-compressive myelopathy, which can go on like that, can have only motor. But spinal cord is a upper motor neuron disease. So you should very highlight that there is no upper motor neuron finding. So what upper motor neuron finding you specifically look for? Here there is wasting, fasciculation is there. What is the upper motor finding which we carefully look for, which will tell you it is in the spinal cord? Which you have been finding?
Spasticity and hyperreflexia and hypertonia will be then.
Which specific reflex? Which one reflex which will tell you that it's in the spinal cord and above? Plantar reflex. You have to carefully look for the plantar reflex, and that will tell you. Babinski is the one which is. And again, in your presentation, when you have written the findings, please remember this entire findings are on the left hand, isn't it? Left-sided findings. So all the findings should come in the third column. Do not swap the columns. Second column is right side. Third column is left side. Neuro has to go in that order just for to avoid confusion, because all your findings were there in the second column. So generally, if we see in the middle, we'll think it is right. Okay, fine. And you went on saying something like a Hirayama's disease. There is a much more commoner variant of the disease in South India. Any idea? Named after a place. We're not able to hear you.
Am I audible, sir? I can hear you. I'm not sure of the South Indian.
Madras motor neuron disease. Have you heard of it? That's more common in the south rather than the Hirayamas or the Chopras, which is in the north.
Okay, who is the pioneer in this work? Monomilic MND from Bangalore. Hello.
You have reviewed a lot of literature. You would have definitely found his name.
Because
you reviewed a lot of literature. You would have definitely found that name. It's such a pioneer.
World Authority on Monomilic MND.
Not able to hear you.
I think your time is up.
Yeah. Okay, fine. Thank you.
Audible.
Yes, Mr. Ritvik Patnaik is a fourth-year student from High Tech Medical College, Bhubaneswar, Orissa. Welcome to you and all the best, Ritvik.
Yes, sir.
You can start.
Sir. Yes, sir. Presenting the case of Mr. XYZ, a 32-year-old male from Patia, Bhubaneswar, who is a security guard by occupation, was admitted on 4th October and was examined on 11th October, presented with the complaints of unpleasant awareness of his own heartbeat since last 4 months, and breathlessness since last 2 months. Now moving on to history of presenting illness. Patient was apparently all right 4 months back. To begin with, he noticed an unpleasant awareness in his own heartbeat in the form of pounding sensation, which was sudden in onset, initially on and off, and now continuously for 2 weeks. It was irregular in nature. There was no aggravating or relieving factor. There is no history of loss of consciousness or chest pain. There is no history of polyuria. Now, breathlessness. The breathlessness was insidious in onset and it was gradually progressive. Initially, the patient was breathless on walking a distance of 500 meters, but was able to carry out his day-to-day activities. But now, over the past 2 weeks, it has progressed to a state where he feels breathless even at rest. Orthopnea is present and there is no history suggestive of PND. There is history of fatigue present over the last 3 months. There is no history of chest pain or syncope. There is no history of pedal edema or abdominal distension. There is no history of weight loss or intolerance to heat or cold. There is no history of cough, wheeze, or hemoptysis. There is no history of decreased urine output. The past history. Patient had an episode of fever and swelling of joints at 11 years of age. He was diagnosed to have a cardiac problem and was started on medication. He does not recall the diagnosis. On routine follow-up at 29 years of age, patient was advised surgery. Patient was unwilling to go ahead with it. There is no history of cyanotic or squatting episodes in the childhood. There is no history of hypertension, diabetes mellitus, hyperlipidemia, or any thyroid disorder. Family history. There is no history of congenital heart disease, ischemic heart disease, obesity, diabetes mellitus, hypertension, or sudden cardiac death in the family. Now moving on to personal history. He is a security guard by occupation. He follows a non-vegetarian diet. His appetite is normal. His sleep is disturbed. He consumes 30 ml of whiskey daily at night. There is no history of smoking or IV drug abuse. The bowel and bladder habits are regular and normal. Now moving on to the medication history. He is on tablet penicillin B 250 mg BD. Now the summary according to the history. Here is a case of a 32-year-old man with significant past history suggestive of rheumatic fever on penicillin prophylaxis, who presented with palpitation since last 4 months and breathlessness since 2 months, which is associated with orthopnea and fatigue. There is no associated history of chest pain, edema, syncope, or hemoptysis. The most probable system involved would be the cardiovascular system. My provisional diagnosis is a valvular heart disease, probably rheumatic in origin, with features of left-sided heart failure with arrhythmia, probably atrial fibrillation. Now, general physical examination. The patient is conscious, cooperative, and well-oriented to time, place, and person. Patient is dyspneic and tachypneic at rest. He is moderately built and moderately nourished. His height is 170 centimeter, weight is 65 kg. The BMI is 22.5 kg per meter square. There is no pallor, icterus, cyanosis, clubbing, edema, or lymphadenopathy. There are no markers of rheumatic fever. There are no markers of infective endocarditis, and there are no peripheral signs of aortic regurgitation. Now moving on to vitals. The pulse is 147 beats per minute, variable volume, irregular, equally felt on both the sides, no radial or radiofemoral delay. Condition of vessel wall is normal. Peripheral pulses are palpable, no special character, and apex pulse deficit of 17 is present. Temperature was 101.9 degree Fahrenheit. Respiratory rate was 24 times per minute abdominothoracic. Blood pressure was 100 by 70 millimeters of mercury measured in the right upper arm in supine position, and the JVP was not elevated. Now, systemic examination of the cardiovascular system. On inspection, there was no sternal or spinal deformities. Trachea was central. The apex beat was visible at the left 5th and 6th intercostal space, 1 cm lateral to the mid-clavicular line. The precordial bulge was absent. Engorged veins were absent. Visible pulsations were absent, and the scars were absent. On palpation, trachea position is confirmed to be in the midline. Apex beat is palpated at the left 5th and 6th intercostal space, 1 cm lateral to the mid-clavicular line. It is hyperdynamic in character. There is a left parasternal heave of grade 2 is present. A systolic thrill present as the apex. Percussion was deferred due to the risk of dislodgement of clots. Now on auscultation on the mitral area, S1 is variable and S2 is heard. Murmur was present. The murmur was a soft musical blowing murmur, high-pitched pansystolic murmur. It was grade 4 in intensity, best heard with the diaphragm of the stethoscope. Patient is lying in the left lateral position with breath held in expiration. The murmur radiates toward the left axilla and inferior angle of scapula. The maneuvers done with it was louder when the patient was made to squat or after the hand grip. On the tricuspid area, S1 and S2 were heard and no murmurs or added sound. On aortic area, S1 and S2 were heard and there were no murmurs or added sound. On pulmonary area, S1 and S2 were heard and no murmurs or added sound. On examination of other system, the GI examination was there was soft and non-tender abdomen, no organomegaly, and no ascites. Respiratory system, vesicular breath sound were heard over all long fields. There are no rhonchi or crepitation. On nervous system examination, higher mental functions are normal, and there were no focal or neurological deficits. Now the diagnosis: a case of acquired valvular heart disease, probably rheumatic etiology, involving the mitral valve in form of chronic severe mitral regurgitation, now complicated with atrial fibrillation with rapid ventricular response and left heart failure with no signs of infective endocarditis. Thank you, sir.
Good presentation.
Yes, sir.
Yeah. Now there are some oddities. This thing you said, the congestive heart failure or left heart. Is it congestive heart failure or left heart failure?
Left heart failure.
Why did you say left heart failure?
Sir, because orthopnea was present.
Okay. Anything else?
And orthopnea spread, and it is a case of severe mitral regurgitation. And in severe mitral regurgitation, when the left heart proceeds to fail, there will be forward symptoms like low blood pressure, orthopnea, or fatigue.
Is it forward symptom or backward symptom?
Forward,
is it a forward failure symptom or backward failure symptom?
Forward failure symptom.
Okay. Okay. Concept of backward failure symptom and forward failure symptom. Okay, fine. Then you said JVP is not elevated and there is no hepatomegaly as well.
Yes, sir. JVP is not elevated.
And you said only about fatigue, easy fatigability.
Yes, sir.
Now, your history, the diagnosis said is a chronic severe mitral regurgitation, but the symptom is only for 4 months, isn't it? Why is that disparity?
Yes, sir. Sir, the palpitation started since last 4 months.
Yeah, true. The symptom is only for 4 months. Is it a regular palpitation, irregular palpitation?
Irregular palpitation.
So in a chronic mitral regurgitation, what are the common symptoms you get?
In a chronic mitral regurgitation, in mild to moderate cases, in mild cases, the patient will be asymptomatic, and the first clinical feature will be a palpitations. There will be palpitations due to an enlarged heart.
Yeah. Palpitation due to enlarged heart. Okay.
Yes, sir.
Any other mechanism you think of?
Yes, sir. Normal heart can also cause palpitation if there is a disturbance in the sinus rhythm.
Okay.
Rhythm disturbances in the normal heart.
Then why do you say it's a chronic severe mitral regurgitation? Chronic. Why did you put in the chronic?
Yes, sir. Because at 29 years of age, patient was advised to do surgery, but the patient denied for surgery.
Without any symptoms? You had given symptoms only for the 4 months. That is puzzling me.
Yes, sir.
So why at 29 years patient was suggested surgery?
He was taking penicillin prophylaxis for acute rheumatic fever.
Yeah. You please understand, penicillin prophylaxis is given to prevent the recurrence of the rheumatic fever, relapse of the rheumatic fever.
Yes, sir.
Then surgery is advised only when there is a rheumatic valvular heart disease, valvular disease.
Yes, sir.
That too, not in mild moderate disease. Mild moderate disease are managed with the medical management. Only in severe disease.
Yes, sir.
So what are the indication, what are the symptoms which will tell you that patient has got significant disease or severe disease? But in your history, you did not mention.
Other than palpitations, which is the other symptom which they should have?
Breathlessness.
Exertional dyspnea, which is worsening exertional dyspnea. That
See,
would
even
indicate that
palpitation, you have mentioned only about 4 months symptom.
Only 4 months.
Only
Yes,
4
sir.
months. Okay, fine. Otherwise,
Yes,
I think everything is fine. Yeah, Archit, and one more thing which I found very odd is in the inspection, you have mentioned about apical impulse could be visible in the 5th to 6th intercostal space, 1 centimeter lateral to dash dash dash. How did you
Yes,
measure
sir.
those 4th intercostal space, 5th intercostal space on inspection? You need to correct that. You
Yes,
need to modify that in future. On inspection, you cannot
Yes, sir.
count the rib space or intercostal space, or you cannot measure the exact distance. That is a palpatory finding.
Yes,
Okay.
Yes,
Fine.
sir.
Otherwise, I find everything is fine. Yeah, Archit, anything?
So
Let's carry on with discussion.
how will you investigate this patient?
Sir, for investigation, first we have to do a ECG. On
Yes.
ECG, we have to look for the left axis deviation to find, and also we have to look for
What?
atrial fibrillation.
Atrial fibrillation. Okay.
Yes,
Then
sir. On atrial if the atrial fibrillation will be present, there will be absence of P waves and narrow QRS complex and irregular RR interval.
what else? What else?
Yes, sir.
Investigation?
Then we have to do a chest X-ray. Chest X-ray, we will say cardiomegaly or irregularity in the left heart border, and splaying of carina, and then chest X-ray. We also have to look for the signs of heart failure, like curly B lines, batwing appearance, and
When will the batwing appearance?
hyper-
When will the batwing appearance appear on an X-ray?
once there is exertional dyspnea and
Any
there is
specific pressure above which you get that classical batwing appearance. You said curly lines, all correct. They are all seen earlier.
Yes, sir.
Batwing appears when?
No, sir, not ever.
Okay, no problem. Next investigation.
If you
Next
see a
investigation was-
calcification, where do you look for calcification in the mitral wall?
On an
Any
X-ray,
idea?
can you make out?
No, sir.
Okay. No, that also you should know
Oh,
how to differentiate between the
Yes, sir.
aortic wall calcification and mitral wall calcification. What line to
Yes, sir.
differentiate that? Okay, fine.
Sir.
It's nice to know. Yeah.
Other
Then we have to
than
do echo. Echo.
other than rheumatic fever, what are the other causes of mitral regurgitation?
Other causes can be SLE and rheumatoid arthritis. All
Common because you have done some dynamic
also.
auscultation.
And
which
yes,
should not
sir.
have done in a patient with atrial fibrillation.
It can be a secondary to LV infraction, secondary to left ventricular dysfunction.
Okay, any the
Mitral
dynamic
regurgitation.
auscultation, which is that? Which MR you get the dynamic auscultation?
Yes, acute MR.
Not in acute. Any other, some problem with the valve only, other than rheumatic?
Yes, sir. No, sir.
My dear.
Then why did you look for the dynamic auscultation?
Dynamic auscultation to know about the murmur.
What murmur?
Pan-systolic murmur was present.
True, that is heard even in the without dynamic when the patient in left lateral position, isn't it?
Yes, sir.
Why did you make the patient squat and stand up?
To see the normally S2 is normally mitral regurgitation.
It's okay. It's a
Yes, sorry, sir. Presenting a case of a male patient named Mr. ABC, age 45 years, who's completed his education till 10th standard. He's a water supplier by occupation and residing in Ramnagar, Bangalore.
and he belongs to a lower middle class of socioeconomic status. His date of admission was 10th of October 2021 and date of examination was 11th of October 2021. He presented with chief complaints of swelling of lower limbs since abdominal distension since 15 days, swelling of lower limbs since 12 days, and yellowish discoloration of eyes since 12 days.
Good.
Rekha, click the cursor on the slide and then press next.
Yes, sir.
Yeah, okay.
Sorry. History of presenting illness. Patient was asymptomatic before 15 days when he developed abdominal distension, which was insidious in onset, gradually progressive. It was uniformly distended abdomen. The distension of the abdomen changes with the position. He had no aggravating and relieving factors. The distension of abdomen was not associated with breathlessness and was not associated with pain abdomen. The patient also complains of swelling of lower limbs, present since 12 days, insidious in onset, gradually progressive, such that initially he noticed it around the ankle and currently it progressed till thighs. He had no diurnal variation in the swelling of lower limbs, no aggravating and relieving factors, no history of pain and redness of limbs, no history of breathlessness and chest pain, no history of facial puffiness and decreased urine output. Patient presented with yellowish discoloration of eyes since 12 days, insidious in onset, initially noticed by his wife, which was non-progressive. It was not associated with any itching, no history of clay-colored stools, no history of high-colored urine. He had no history of fever, pain abdomen, no history of blood in vomit, blood in stools, and black tarry stools. He has no history of breathlessness, confusion, involuntary movement, and changes in the sleep pattern. No history of decreased urine output. He has no history of decreased appetite and weight loss. Past medical illness, he had similar complaints of abdominal distension and yellowish discoloration of eyes 10 months back, which persisted for 15 days, and he was treated for the same and he was relieved of the symptoms. He has no history of diabetes, hypertension, and tuberculosis, no history of tattoos, piercing, or blood transfusions in the past. He has no history of past surgical interventions. Drug history, he had no significant drug history. He has no history of allergies to any drugs in the past. Family history, there is no significant family history. Personal history, he consumed some mixed diet, his appetite was normal, sleep was undisturbed, bowel and bladder movements were regular. Addictive habits, he consumes ethanol since 20 years, which is he consumes 180 ml per day, which approximates to 7.2 units per day. He has no history of smoking or IV drug abuse. To summarize, a 45-year-old male presented with abdominal distension, swelling of lower limbs, and yellowish discoloration of eyes with similar complaints in the past and history of ethanol consumption since 20 years. It probably involves the hepatobiliary system, and my probable diagnosis is a decompensated liver disease, and probable etiology is ethanol consumption. General physical examination, patient's consent was taken, patient is well built and nourished, patient was conscious, cooperative, and well oriented to time, place, and person. He was examined under adequate light and exposure. Pallor was present, icterus was present, cyanosis, clubbing, and lymphadenopathy were absent. Edema was present in the lower limbs till knees. It was a fast pitting type of edema. Vitals, pulse was 68 per minute, normal in rate, rhythm, character, volume, and the arteries are all palpable and no delays were present. Blood pressure was 118 by 80 millimeters of mercury measured in right arm sitting position. The respiratory rate was 18 cycles per minute, thoraco-abdominal. Temperature was afebrile, which was 98.4 degrees Fahrenheit. JVP was normal, 6 centimeters of H2O. Head-to-toe examination, no alopecia, and no bite or spots, case of Leisure ring, no xanthelasma, no parotid enlargement, fetor hepaticus, or spider nevi, no palmar erythema, diputous contracture. Nails were normal, no flapping tremors, gynecomastia, loss of axillary and pubic hair, no dilated veins over the abdomen, no scratch marks, no testicular atrophy, no petechiae or purpura. Systemic examination, on abdominal examination, patient's consent was taken and was examined under adequate exposure and light. Inspection was done in supine position with knees and hips flexed. Before that, in a standing position, we looked for dilated veins. There were no dilated veins. There was generalized distension of abdomen. Flanks appeared full. Skin is glossy. Umbilicus was everted. Corresponding quadrants move equally with respiration. No scars of the abdomen. No visible peristalsis or scratch marks. On palpation, it was done in the supine position with both the lower limbs flexed. On superficial palpation, there is no local rise of temperature, tenderness, guarding, or rigidity. On deep palpation, by dipping method, liver was palpable 4 centimeter below the right costal margin. It was firm in consistency, edges are round, nodular surface, non-tender and non-pulsatile. Spleen and kidney were non-palpable. Abdominal girth was 108 centimeter, measured at the level of umbilicus. Xiphisternum to umbilicus was 39 centimeter. Umbilicus to pubic symphysis was 24 centimeter, whereas the right-sided umbilicus to anterior superior iliac spine distance was 38, and left side it was 38 centimeter. On percussion, liver dullness, upper border of liver dullness was elicited in the fifth intercostal space in the right midclavicular line, and lower border could not be percussed. Spleen dullness could not be percussed. Shifting dullness was present, and fluid thrill was not present. On auscultation, bowel sounds were heard 4 per minute, no venous hum, no bruit were heard, no friction rub, and external genitalia examination was normal. Respiratory system, normal vesicular breath sounds heard, no added sounds. Cardiovascular system, S1 and S2 heard, no murmurs were present. Nervous system examination, no focal neurological deficit, no tremors present, no involuntary movements present, and the reflexes were normal. Provisional diagnosis. My probable diagnosis is decompensated chronic parenchymal liver disease, etiology being most reliably ethanol consumption associated with ascites, and no features suggestive of other complications of decompensated chronic liver disease. Thank you.
Okay, presented well. Hello, am I audible?
Yes, sir.
Yeah, presented well. Now you said, keep your slide on the last slide.
Okay, sir.
Yeah, you said you were diagnosed with decompensated chronic parenchymal liver disease. What made you to think that it's decompensated liver disease?
So the presence of symptoms like yellowish discoloration, jaundice, or ascites all signifies it is a decompensated liver disease.
Okay. Okay. What made you to think that it's chronic parenchymal liver disease?
So because he already had a similar history 10 months back, and he was treated for the same. He had abdominal distension and yellowish discoloration of eyes. Okay. So it is there for more than 6 months, so it is a chronic liver disease.
Okay, fine. Any history of hepatitis in the past? History suggestive of hepatitis in the past?
No, sir. There is no history of hepatitis in the past.
No, history suggestive of hepatitis, jaundice in the childhood.
No, there was no history of jaundice in the childhood.
Okay. You mentioned about something about pulsatility of liver in an examination. I was wondering, yes, how do you look for pulsatility of liver?
Sir, if it is, we have to check it along with the carotid pulse. There'll be alternating.
One sentence. What is the method of looking for pulsatility of liver, pulsatile liver? I just want to make sure that you have, the concept and you mentioned it, or just for the completion sake you've written?
No, while doing the dipping method, when you palpate the lower lobe, that time you have to feel for
which condition do you get that pulsatile liver? Which condition are you aware where you get this pulsatile liver?
Tricuspid regurgitation, tricuspid regurgitation and stenosis.
Yeah, that is true.
Supposed to hold the liver, feel whether it is pulsatile. You're supposed to hold the liver. So how do you supposed to hold the liver? Then you can make out whether it is pulsatile. So this is what this case is an acute decompensation of a chronic liver disease. So the new symptom has started recently. So it's an acute decompensated chronic liver disease, ACLD. That's the word you have to use here. You said this patient has ascites but no dilated veins. No dilated veins, spleen could not be palpable. So what do you think this complication this patient is having? What complication?
So it could be a hypoproteinemia, just the disease limiting to the liver. If there was portal hypertension, then the ascites could, if the ascites were due to portal hypertension, then they can have splenomegaly and dilated veins.
Why do you think the patient does not have splenomegaly and dilated veins?
No, sir.
Hello?
Hello. Sir, can you hear, sir?
Yeah. So do you think the splenomegaly and dilated veins have disappeared? Could it have been there and has gone disappeared? Any
Complaints in the
complication?
past also. He didn't notice any.
Any
He didn't have any other symptom.
Any complication
Other
which can make the
symptoms
spleen
of
disappear?
portal hypertension, like a splenic infarct, can.
What is the mechanism of splenomegaly in a cirrhosis or portal hypertension? If you understand that, it will be easier. What is the mechanism of splenomegaly?
Because of increase in the portal venous pressure.
That means congestive splenomegaly. It is congestive splenomegaly. So what complication can shrink the spleen?
Remove the congestion.
Diuretics. And
No.
Diuretics
You had given it in the history, but you should apply that. Suppose the patient had upper GA bleeding or lower GA bleeding, or GA bleeding. What can happen? That can acutely decongest the portal venous pressure, isn't it? And the spleen can. Yeah. How do you continue your diagnosis? How do you confirm your diagnosis?
So first, investigations, liver function test can be done, where the liver enzymes can be assessed. In alcoholic liver disease,
one interruption here. How do you know that it is chronic liver disease, or is it only alcoholic hepatitis? 10 years, 7 years, 7 months back, alcoholic hepatitis. Now again, relapse of the alcoholic hepatitis. Because he doesn't have edema, isn't it?
Sir, yes, sir.
He has edema. Okay, fine.
Yes, sir.
So, yeah. How do you differentiate whether it is hepatitis or chronic liver disease? What test will help you to differentiate?
So, serology can be done.
What test? Alcoholic hepatitis.
To rule out past
by looking at the LFT. By looking at the LFT, how do you know that? Is it a hepatitis or chronic parenchymal liver disease?
Peptidases and gamma glutamine peptidases.
Anything else?
Elevated in alcoholic liver disease.
Yeah, which of those function of the liver will be affected in chronicity? Which function? Production.
The albumin synthesis will be decreased.
That's albumin.
Yes. In acute decompensation, acute hepatic failure, which function will be abnormal?
There'll be increased hyperbilirubinemia.
First one to get affected. First liver function to get affected.
Within a few hours.
Acute condition, which is that?
The clotting factors synthesis can be affected.
So what is that test?
Prothrombin time.
Prothrombin.
What is the management plan for this patient now?
So he's a moderate ascites, so salt restriction is advised, and diuretics. He can.
But basic cause has to be treated, isn't
it? Yes, sir. Stop alcohol consumption, and then he has to be put on bed rest, and then salt restriction should be restricted to less than 40 millimoles over 24 hours, and then he can be put on diuretics like.
Which diuretic?
Spironolactone 100 mg, and then add on spironolactone, and it can be add on like loop diuretics can be added like furosemide 40 mg we started with, and then in case if it is a massive ascites, then we can go for parasynthesis.
Okay, I'll go back to investigation. What hematological abnormality you will see in a chronic liver disease? Common things.
So there can be pancytopenia to hypersplenism.
Pancytopenia. Okay, fine.
Then the RBC, and there can be megaloblastic anemia also because of nutritional vitamin B12 and folate deficiency, and serum.
Fine. Archit?
Yes. Okay.
Serum electrolytes can be affected.
Okay.
Bangalore, are you ready?
Yes, sir. Could I start the presentation?
Please. Yes, go ahead.
Yes. My patient is a 55-year-old male hailing from Malleshwaram who is a teacher by occupation. He presented to the OPD with a chief complaint of difficulty in walking since 6 months, difficulty in writing since 4 months, and speech disturbances since 1 month. Patient was apparently normal 6 months back, after which he developed difficulty in walking in the form of unsteadiness and swaying towards both the sides. It was insidious in onset and gradually progressed from initially requiring wall support to now using walking sticks. There's no history of stiffening of limbs, no history of tingling sensations, pain. There's no history of worsening of symptoms on closing the eyes or in a dark room. There's no associated vomiting or fullness of the ear. There's no history of double vision or difficulty in swallowing, and no history of falls. Patient also complains of difficulty in writing, brushing, eating, holding cup of water, and dressing with both his upper limbs due to tremors and incoordination since the past 4 months. He also experienced difficulty of speech since the past 1 month, which was insidious in onset and progressed from initially having difficulty in articulating a few words to presently having slurring of speech. There's no history of difficulty in understanding instructions and following commands, and no history of difficulty in reading. Past medical illnesses. He has no similar complaints in the past, and the patient is not a known case of diabetes, hypertension, cardiovascular disease, TB, or epilepsy, and is not on any chronic medications. There's no similar history in the family, personal history. The diet is mixed, appetite is normal, sleep is adequate, his bowel and bladder are normal. He consumes alcohol on occasional basis, and there's no other ill habits. General physical examination. Patient is conscious, cooperative, coherent, and well-oriented to time, place, and person. He's moderately built and nourished. Pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema were absent. His height is 160 centimeters and weight is 58 kg. His BMI was 22.7 kg per meter square. Thyroid and spine examinations were normal. There was no evidence of ptosis, squint, no evidence of xanthoma, acanthosis nigricans. Vitals. So all the vitals examination was normal. On higher mental function, everything except speech was normal. His speech was slow, slurred, scanning speech, and cranial nerve examination was normal. On motor sister examination, bulk was normal and symmetrical, and there was no wasting seen. Tone was normal on all the limbs. Power was 5 by 5. Superficial and deep reflexes were all normal. Deep tendon reflexes were normal. On sensory examination, the dorsal column and spinal thalamic column sensations were all intact. Cerebellar system examination, titubations were absent. He had slow, slurred scanning speech. Dysmetria and intentional tremors were present on finger nose test, and knee to toe test was jerky. Dysdiadokinesia was present. Nystagmus was present in lateral gaze. Rebound phenomena and pendular knee junk were absent. Gait was broad based and unsteady. Intentional tremors were present, and there was no truncal ataxia. On examination of other systems, cardiovascular system, S1 and S2 were normally heard. There were no murmurs and no carotid bruits. Respiratory system were normal. Normal vesicular breath sounds were heard. No added sounds were present. On abdominal examination, abdomen is soft, non-tender, and no organomegaly was seen. To summarize, here is a middle-aged male patient who presented with slow progressive ataxia, incoordination causing inability to perform routine activities like writing, brushing, and speech disturbances. There were no associated sensory motor or vestibular complaints. On examination, he had scanning speech, dysmetria, intentional tremors, dysdiadochokinesia, nystagmus on lateral gaze, and wide-based gait. Provisional diagnosis. A functional diagnosis was ataxia, incoordination, and scanning speech. It's probably localized to the cerebellum, and this appears to be a degenerative condition. Yes, sir.
Okay. Good presentation again. all are one above another. Yeah. Now, why do you think it's a degenerative condition, cerebellar disease?
So I thought
Why do you
it's
cerebellar disease? I got all the findings you have told most of the time. Why do you think it's a degenerative disease?
So based on the initial differentials could be like ischemic or degenerative, but ischemic conditions would generally be acute in onset. But since this history is present for like around 6 months, it appears to be degenerative condition.
What are the common toxins which can produce cerebellar dysfunction?
Alcohol, then it can be like glue. Then there can be even drugs like phenytoin and many anti-epileptic drugs.
So did you take the history of drug intake?
Yes, sir. He has no chronic drug usage.
Okay. So which structure was? Yeah.
Any other causes other than ischemia and drugs and toxins? Any other causes? Any other causes of cerebellum?
Yes, sir. It can be due to vitamin B1 deficiency, vitamin B12 deficiency. Then it can be due to Wernicke's, which is because of chronic alcoholism. It can also be due to acute alcohol intoxication.
Endocrine disease.
Yes, sir. Hypothyroidism can cause cerebellar disorders like this.
All these things you have to consider before we say it as degenerative.
Yes, sir.
You have to rule out all these other conditions before we say it is degenerative.
Yes.
You said the cranial nerves were normal. Nystagmus comes in the cranial nerves. No? You can't say it as cranial nerves are normal. You have to say nystagmus is there in that present.
Yes. Yes, I will change that.
Would you like to do a Rombox test in this patient?
Sir, since this patient appears to have a cerebellar condition, I think Rombox test may not be appropriate in this case. But it is mostly done in order to find out if there's a sensory cause of ataxia.
Okay. Now, how do you differentiate spinocerebellar degeneration? If there is spinal component, how do you find out?
So spinocerebellar degeneration is, so there would also, in the history, we might see a family history also because it's autosomal dominant. And then there might be other sensory features like tingling and numbness.
What else? What is the other main structure that is there in the spinal cord? Other than sensory, what else is there?
The motor, there could be spasticity also.
There could be pyramidal signs.
Pyramidal signs, yes.
Extensor, plantar, etc. will be there.
Okay, what are the nucleus in the cerebellum?
So the nucleus would be vestigial, emboliform, globus, and dentate nuclei.
Okay, any specific functions of each of these nuclei?
Yes, so they have specific functions, but I don't remember them.
Okay, fine. Anyway, good.
Other causes of ataxia. Other causes of ataxia other than cerebellum and sensory. You told 2 causes. Any other causes which can produce ataxia?
Yes, so vestibular causes can also cause ataxia.
Correct.
And frontal lobe causes and psychological causes can also cause ataxia.
Visual input is not there. Somebody is blind.
Yes, sir.
They can also have ataxia like that.
Yes.
How will you evaluate?
So we would like to do first we would like to do a complete blood count, and along with that analysis of vitamin B12 levels, vitamin B1, and thyroid function test. And then we'd like to do an MRI or CT scan of the brain. And if none of those find conclusive, then we could go for a genetic testing, but that is little difficult and costly to be available.
What will happen if there is a degeneration of the cerebellum on MRI? Any idea how will it look like?
So it will appear to be a shrunken cerebellum, like an atrophied shrunken cerebellum.
What will it be? Will the foliations become more prominent or less prominent?
The foliations will be more prominent.
Is it? When you say the brain is atrophied, cortex gets atrophied, the gyri become more prominent. Whereas in cerebellum, when it becomes atrophied, the foliations become less prominent. Means it's opposite. Cortex becomes more prominent. Those gyri become more prominent, whereas in cerebellum it becomes less.
Yes, sir.
Okay, good. Thank you.
Good.
Yeah. Next.
Yes.
Yes, today I am presenting a clinical case.
Full screen.
It's full screen, sir.
Yeah.
Yes. Go ahead.
Please start.
Yeah, sir. My patient named Rangya Gowda, age 65 years, studied up to 10th standard. Occupation is a farmer. Hails from Bhubaneswar, Hassan. He belongs to low socioeconomic status according to modified BG Prasad classification. Admitted on 4th of October and admitted on 4th of October and examined on 6th of October. His presenting complaints were complaint of breathlessness exacerbated since 1 day and complaints of cough with expectoration since 1 day. History of presenting illness. Patient was apparently all right 3 years back when he developed breathlessness which was with wheeze, which was insidious in onset, gradually progressive. From breathlessness after doing sternus work and on walking upstairs, breathlessness even at rest. He had previously 6 episodes of exacerbation. Now he is being admitted for the acute exacerbation of the same symptom since 1 day. Now breathlessness. Now recently the breathlessness aggravated by walking even for a few steps. It is more during night time on lying down supine. It relieves on rest with bending forward position and with medication. Again, breathlessness is also associated with the cough with expectoration since 3 years. It was insidious in onset, more in supine position, no diurnal variation, aggravated since 1 day. Expectoration is present, which is white in color, mucoid in consistency, scanty in amount, non-foul smelling, not blood tints, more in the morning. History of orthopnea present, history of weight loss present, no history of fever, no history of paroxysmal nocturnal dyspnea, no history of palpitations, edema, chest pain. Past history, previously there were similar complaints of breathlessness for which he was being admitted to the hospital 6 times and treated for the same. No history of diabetes mellitus, hypertension, tuberculosis, epilepsy, COVID-19 infection. Immunization history, he has taken 2 doses of COVID vaccination. Family history, nothing significant. Personal history, diet is mixed, appetite is decreased, sleep is disturbed, bowel and bladder movements normal and regular. Habits, he is a chronic smoker since 50 years. He consumes 2 packs per day, making 100 packs per year. Chronic alcoholic since 30 years. He consumes 50 ml of brandy per day. Summary, here is an elderly male who is chronic smoker, alcoholic, is having chronic breathlessness associated with chronic cough with scanty expectoration since 3 years, with history of repeated hospitalization for past 6 episodes of acute exacerbation, has now come with acute exacerbation of breathlessness 1 day back, suggestive of MMRC grade 4. Coming to general physical examination, an elderly male patient is poorly built, poorly nourished, conscious, cooperative, well-oriented to time, place, and person. On examination of pallor, icterus, cyanosis, lymphadenopathy, clubbing, it was not present. Vitals, pulse 101 beats per minute, regular, BP 130 by 80 millimeters of mercury, respiratory rate 35 cycles per minute, temperature was afebrile. Systemic examination, cardiovascular system, S1, S2 was heard, no murmurs, central nervous system clinically normal, per abdomen examination soft and non-tender. Examination of respiratory system proper. Coming to inspection, shape of the chest was barrel shaped with kyphosis, symmetry of the chest bilaterally symmetrical, spine, thoracic, lumbar spine kyphosis was present, tracheal position central, apex feet not seen, respiratory movements markedly decreased or respiratory movements bilaterally. Bilateral lower intercostal retractions were present, no visible pulsations, no scars, no sinuses were present. On palpation, no local rise in temperature, no tenderness, apical impulse not felt, respiratory movements are abdominothoracic type, measurements AP diameter was 21 centimeter, transverse 25, chest expansion was 3 centimeters, tactile vocal parameters reduced bilaterally. Here are a few pictures of the patient. Barrel shaped chest are seen here. Intercostal retractions were present, and right clavicular head of sternocleidomastoid mastoid was prominent here. Intraclavicular fossa was present. And here is how we took the transverse diameter and the anteroposterior diameter. This is 25 centimeter. And this is 21 centimeter. Coming to percussion, the areas which we percussed were supraclavicular, clavicular, intraclavicular, mammary, axillary, infraaxillary, suprascapular, interscapular, intrascapular. It was hyperresonant, it was symmetrical, hyperresonant on both right and left side. Cardiac dullness obliterated, trough space tympanic on both sides, cornic systemus resonant, liver dullness on right 6 intercostal space anteriorly was present. Auscultation, intensity of breath sounds were symmetrical but decreased on the same sides, that is supraclavicular, clavicular, intraclavicular, and so on. Vesicular breath sounds was heard with added bilateral inspiratory crepitations were heard. Vocal resonance was decreased but symmetrical on both sides. So coming to provisional diagnosis, the patient, here it is acute exacerbation of chronic obstructive airway disease with hyperinflation without any evidence of cor pulmonale. Differentials, acute exacerbation of chronic or persistent asthma, acute exacerbation of emphysema, or acute exacerbation of chronic bronchitis. Investigations, the investigations that were ordered to the patient were routine blood investigations like hemoglobin percentage, total count, differential count, random blood glucose, urea, creatinine levels, chest X-ray, and ECG. So the management could be supplemental oxygen therapy, inhaled bronchodilators, salbutamol, that is salbutamol, salmeterol, or combination of inhaled corticosteroids and long-acting beta agonists, fluticasone, salmeterol, or systemic corticosteroids. And actually, this should be the first, that is counsel the patient to stop smoking. Thank you, sir.
Go back to your good presentation. Go back to your diagnosis. Provisional diagnosis. Yeah.
Yes.
Okay. Okay, is it a predominant emphysema, predominant chronic bronchitis?
Sir, it is predominant emphysematous.
Okay. The patient is in respiratory failure or not in respiratory failure?
When we examined, patient was normal. There was no signs of respiratory failure, sir.
What are the signs of respiratory failure look for in a COPD patient?
Yes, signs of respiratory failure are, it may be like in COPD, it is type 2 respiratory failure. It can be bounding pulse, it can be high BP, it can there can be hyperinflation, there can be acute respiratory acidosis present. Yes, sir.
Any specific other signs?
I'm not sure, sir.
The hand, you can look for anything. The carbon dioxide increases. What you can look in the hand?
Yes, sir. Hypercapnia.
So what will happen in the hand?
What sign?
Yes, sir.
Sign in the hand. In the hands, you can get something.
Yes, sir. Fine tremors.
Fine tremors.
Okay.
I didn't hear, sir.
Not fine tremors, some other tremors.
I'm not sure, sir.
You said the drop space on both sides. That is wrong. Huh? Drop space is only on the.
So drop space, it's on this one on the right side. Yeah, it's on the left side, sir.
You have written drop space on both sides. That is wrong. Okay, correct that. Drop space is tympanic on both sides. You have written. It is only on the.
Sorry, sir. Only on one.
Yeah. Which condition will have frequent exacerbation? You said 5 to 6 hospitalized in a year. Which condition will have frequent exacerbations?
So, like it can be COPD. The causes, like it can be acute causes, it can be allergic causes. It can be infectious etiology. It can be seasonal, or that's it. That's it.
Yeah, because you have only 3 conditions: chronic asthma, emphysema, chronic bronchitis. Which of these will have frequent exacerbations? Mucopurulent exacerbations.
Which one?
Mucopurulent
chronic bronchitis. Chronic bronchitis.
Okay. Now, why did you say patient is not in cor pulmonale? How did you look for the presence of cor pulmonale, evidence of cor pulmonale, clinical evidence of cor pulmonale?
So clinically, pallor must be present. The patient should
cor
be
pulmonale.
What is cor pulmonale?
So it is left ventricular failure with decompensated.
Left ventricular.
No, not left.
Congestive heart failure.
No. Not congestive also.
Cor pulmonale, pulmonary
specific
edema.
Condition.
Pulmonary edema.
No.
That's what, when you write some diagnosis, you should know about that condition. Yeah, what does that mean? Because you have specifically said without any evidence of corporal mail. So what is the clinical evidence?
Clinically, there was no
Okay, what is the earliest evidence? How do you look for the evidence of corporal mail?
So peripheral cyanosis.
No. You are somewhere far away from the corporal
right
mail.
ventricle will enlarge. So where will you look for the right ventricle?
Yes, sir, right ventricle.
Where will you look
right
for?
ventricle. So right ventricle, we look for at the fourth intercostal space.
Okay.
Okay, you said obstruction. Obstruction. What is the evidence of obstruction that you have in your patient? Obstructive airway disease. What is the evidence you have?
Obstructive, it is the lung. Yes, sir. On clinical examination, the patient had hyperinflation of the lungs with intercostal retractions was present. So it suggests there was there was kyphosis and
where was the obstruction?
The obstruction is at the level of alveolus.
Alveolus. Okay. Okay.
What will happen if obstruction is there in COPD? What sort of breath sound you generally get, or what added sound you get?
Yes, we'll get V's and rhonchi.
Should have that. History, you had V's. And what will happen to the breath sound? How will the inspiration, expiration be?
Yes, there we can hear in inspiration, there can be inspiratory crackles or coarse crepitations can be heard.
Breath sound, very specific. Breath sound.
Breath sounds are bronchial, vesicular. So it is vesicular breath sound, sir, was heard here.
Yeah, with some specificity, some specific feature. When there is a airway obstruction.
What will get prolonged?
Like in bronchial asthma.
What will get prolonged? Inspiration or expiration?
So expiration.
Expiration will prolong. Okay. Yes. So you written the treatment for all those, you said inhalers and all you have written.
Yes, sir.
Isn't it? This patient is getting recurrent. Every month he is getting admitted. Anything else you can do?
Sir, we can give home oxygen therapy.
No.
Prevention of infection. Anything you can do? Prevention of infection?
Yes, sir. Prevention of infection can be done.
How?
By giving antibiotics.
Antibiotics, huh?
Anything else?
You said
mentioned about COVID vaccine.
COVID vaccination, you said something like that.
Yes, sir. Influenza vaccine, pneumococcal vaccine, influenza vaccine.
Correct.
Pneumococcal, there is two types of conjugated vaccine and another one, polysaccharide vaccine.
Okay. Fine. Okay.
Thank you.
Good afternoon, everyone. I am presenting case of Mr. XYZ, 28-year-old male, resident of Daryaganj, Delhi, is an MTech student. History has been given by the patient himself and seems to be reliable. The patient is right-handed and he presented to OPD on 10 July 2021 with chief complaints of diminished sensations in both legs since 20 days, difficulty in walking since 17 days, problem in urination since 15 days. History of present illness. Patient was apparently well 20 days ago when he first felt a band-like burning sensation around his trunk in the upper part of abdomen. It was followed by tingling sensation and numbness in his right lower limb on the same day, which then progressed to the left lower limb over the next 3 days. Patient also has a history of frequent falls since the start of sensory symptoms and occur mainly in the nighttime and while washing face, and no history of electric shock-like sensation present along the spine. Weakness of both legs started 17 days back. Initially, patient complained of slipping of slippers from his feet, which he was not aware of. 1 day later, patient started having buckling of legs after walking a certain distance. Over the next 2 days, patient started having difficulty in standing up from squatting position and chair. There is no respiratory distress and orthopnea, no history of eye pain and history suggestive of cranial nerve involvement. Patient also complains of problem in urination since 15 days. since 15 days. Initially, for 2 days, patient had decreased urine output, which was then followed by increased frequency of urination over the last 14 days with difficulty in stopping the micturition. There is no altered sweating. There is no history of headache, projectile vomiting, seizures, abnormal speech, neck stiffness, photophobia, and change of behavior. Patient has a history of low-grade fever of 1 month back, which subsided spontaneously within 3 to 4 days. There is no history of ongoing fever, backache, swelling in back midline, evening rise of temperature, night sweats and cough. No history of sharp shooting pain in a particular area. No history of recent vaccination. No history of trauma. No history of dog bite, or no history of previous sudden onset eye pain aggravated on eye movements. History of past illness. There is no history of similar complaints in the past. Patient is not a known case of tuberculosis. No history of contact with tuberculosis case. There is no history of hypertension and diabetes. Personal history: patient is right-handed, takes a mixed diet, has normal sleep cycle, and there is no history of alcohol and tobacco abuse. There is no significant family history. Summary: Mr. XYZ, 28-year-old gentleman with a history of low-grade fever of 3 to 4 days, 1 month back, presented with band-like burning sensation in upper abdomen 20 days back, followed by tingling and numbness in both legs over the next 3 days, frequent falls mainly at night time, weakness in right leg 17 days back and then progressed to left leg, probably spastic weakness involving distal muscles initially, followed by proximal muscles, with no fluctuation on exercise and exposure to hot environment, with no signs suggestive of brain involvement. Also, patient has truncal weakness, problem of micturition since 15 days. There is no history of ongoing fever, back pain, radicular pain, trauma, previous episodes suggestive of optic neuritis, previous similar episodes of weakness. Differential diagnosis: patient probably has an acute myelopathy with a level of lesion in the thoracic cord due to a non-compressive etiology. Transverse myelitis is the probable pathology, and it can be post-infectious as the patient has a previous history of fever. It can be due to multiple sclerosis, neuromyelitis optica, can be infectious or can be primary. Examination: general physical examination has been done in a well-lit room. Patient is in lying down position. He is bedridden with extension of hip and knee joint and flexion of ankle. Patient is conscious, well oriented to time, place, and person, and is cooperative, has a moderate build. Vitals: pulse rate is 75 beats per minute, regular, good volume, normal character, no radioradial and radiofemoral delay, all peripheral pulses are palpable. Blood pressure is 130 by 80 millimeter of mercury in right brachial artery in supine position. Respiratory rate is 18 per minute, is abdominothoracic and regular. Temperature is 98.5 degree Fahrenheit. There is no pallor, icterus, cyanosis, clubbing, lymphedema, pedal edema. CNS examination: higher mental function are normal. All cranial nerves are normal. In motor examination, bilateral lower limb has increased tone with spasticity. Both upper limb tone is normal, and there is no visible muscle wasting, fasciculation in upper and lower limbs. Power in lower limbs: both hip and knee muscles have a power of 3/5 bilaterally, and bilaterally ankle muscles have a power of 1/5. In upper limb, the power is normal in all muscle groups, and pronator drift sign is absent. Truncal weakness is present. Reflexes: deep tendon reflexes of lower limb are knee reflexes exaggerated bilaterally, ankle reflexes exaggerated, and clonus is present. Upper limb reflexes are normal. Superficial reflex: abdominal reflex are absent bilaterally, cremasteric reflex is absent bilaterally, anal reflex is also absent bilaterally, and plantar reflex shows Babinski sign positive. On sensory examination, upper limb has all sensations intact. In trunk and lower limb, there is no pain, temperature, crude touch sensation felt in both lower limbs and T6 to T12 dermatomes. Hyperesthesia is present just above the T6 cord level. Diminished vibrations present in lower limb and over spinous processes up to T4 cord level. There is diminished joint sense. Cortical sensations are normal. Coordination is normal in upper limb, but could not be assessed in lower limb. Gait: patient cannot walk. There are no signs of meningeal irritation. There is no spine tenderness, no bony deformity present. Other examination, there is no significant finding. So overall case summary: Mr. XYZ, 28-year-old gentleman with a history of low-grade fever 1 month back, presented with acute onset of bilateral symmetrical lower limb weakness progressing from distal to proximal muscles with no fluctuation on exercise in hot environment. Truncal weakness present, burning band sensation at the level of xiphisternum, numbness and tingling sensation in both legs, frequent falls increasing in night time, and with abnormal micturition. On examination, spasticity is present in both legs, exaggerated lower limb deep tendon reflexes, and absent superficial abdominal chemistic anal reflex and Babinski sign, positive on both sides. Sensory level is present at T6 with pain, temperature, crude touch sensation lost beyond T6 dermatome. A vibration sense diminished till T4 cord level and joint sensation diminished in lower limb. Presumptive diagnosis. It is a case of acute paraparesis of upper motor neuron type with a sensory level at T4, probably due to an acute myelopathy caused by post-infectious transverse myelopathy or multiple sclerosis or neuromyelitis optica spectrum disorders. Thank you.
Yes. Good presentation again. Keep in the same slide. Yeah.
Okay.
The history you said it is progressed to over 3-4 days.
Yes, sir.
His maximum weakness was attained not on the day 1, day 2. It is on 3rd, 4th day. That's what I assume.
Yes, sir.
Okay. Any other differential diagnosis can you put when the disease is progressive or weakness is progressive over several days? What will be the history, typical history in a transverse myelitis? Progression of weakness.
So the weakness will develop usually within 1 to 2 days, and if the cause is autoimmune, then the weakness will start to decrease after some time.
Decreases. Okay. Now, would you put it as a complete cord lesion or anterior cord lesion or posterior cord lesion, anything like that? Would like to anatomic localization?
Sir, can you repeat, please?
Yeah, you have put it as a acute paraparesis.
Yes, sir.
Is it a complete transection of the spinal cord or anterior cord syndrome?
Sir, it is complete because the posterior column is also involved.
You said vibration and the position is retained.
No, sir. It's absent.
Proprioception is retained.
No, sir. Diminished. Sir, there is a history
diminished is different and absent is different. Absence is different.
Sir, it is absent. Yes, I mentioned diminished.
Yes, you have mentioned diminished. That's why I'm asking you. Okay. Any other differential diagnosis you'd like to put for this complete cord lesion or acute paraparesis?
Sir,
apparently you have put the sensory level. I do agree.
Yes, sir. There can it can also be a peripheral neuropathy, like it can be a Guillain-Barré syndrome. Or
will you get a sensory deficits like this in GBS?
No, sir. No. It is only a differential diagnosis of acute paraparesis. There will be no sensory involvement. Also,
anything else wherein you will get a sudden onset of paraparesis, which may mimic your transverse myelitis. What significant finding you would have looked in the lower limb in general examination?
Don't know.
No, something vascular lesion can present in similar way, isn't it? You have put a differential diagnosis only for the demyelinative disease, plaques, and other things.
So vascular lesion, either if it is in spinal cord, then it can be anterior spinal artery syndrome, but the posterior column is involved, so I have ruled it out. Okay. Also, if it is an acute event in the brain, it can be an unpaired anterior cerebral artery infarct, but the cortical functions are normal.
Okay.
Sensory wouldn't be involved, isn't it? In front, if there is a brain involvement, you wouldn't have this sensory. When you said that anterior spinal, what is what lower limb examination finding you will get? If there is an acute vascular problem, which has completely caused damage to the spine.
So pulseless.
Pulseless, isn't it? Correct. Pulses in the lower limb. That is what you will have. Be absent. Dissection or an embolism.
So dissection, aortic dissection, which can have the complete. Okay. Now we also have mentioned something about the bladder, I believe.
Yes, sir.
He was not catheterized. He was passing urine. Another thing.
Sir, in the initial 2 days, he could not pass the urine, but after that he could pass urine. After 2 days, there was automatic bladder causing the urge incontinence.
Automatic bladder causing urge incontinence. Okay. Okay. Now, what are the current status of his? The duration of 3 weeks.
Improved or it remained like that?
Sir, the weakness, there has been no improvement in the symptoms.
No improvement.
You have also mentioned that there is spastic limb. In a acute, it's a duration of the illness only 3 weeks, 2 weeks to 3 weeks.
Yes, sir.
And you have mentioned it is a spastic limb, spastic lower limb.
Yes, sir.
Is it appropriate?
Sir, if the
What do you
spinal
anticipate?
sir, if the spinal shock has relieved, then there can be spastic involvement.
Okay, okay. Because you said UM and paraparesis.
Yes.
And I think in the history, you did not mention anything about upper limb involvement. That's what I did not hear anything.
Sir, I mentioned that there is no
Okay, fine.
upper limb weakness.
Agreed. Where do you look for Beaver sign?
Sir, Beaver sign we will look for, sir, at the near umbilicus we will ask the patient. Sir, we will ask the patient to raise his legs at hip joint, and we'll check if there is deviation of the umbilicus.
What does it say? If it is present, what does it signify?
If it is present, that it suggests that the cord lesion is around T-TEML level.
Okay. What history would suggest that patient has got NMO? You were talking about NMO.
Sir, if there would have been associated bilateral optic neuritis.
Bilateral is mandatory?
Sir, usually in NMO bilaterally.
What history?
So the patient will give history of sudden onset eye pain, and which will characteristically increase on eye movements. Also, the color vision will be decreased.
Okay. Dimness of vision. Okay, fine. Archit?
Yeah. Compressive myelopathy, you said if this is non-compressive. Why are you ruling out compressive myelopathy? Why can't it be a compressive?
Sir, I've ruled out the extramedullary compression because once there is no back pain, there is no back swelling, there is no history suggestive of roots involvement, as there is no root pain, so no root pain compression. Also, there is early bladder involvement, so it will not be present in an extramedullary lesion.
All non-compressive myelopathy, the first thing that we have to do is to rule out compression. Because compression is correctable. You can do something for the compression. Most of the non-compressive things, sometimes you may not be able to do. So whenever we evaluate a non-compressive myelopathy, we have to rule out compression. All your algorithm will start with rule out compression. Can you give some examples for compressive myelopathy?
Sir, if it is extramedullary, it can be port spine, it can be a vertebral fracture, or if there are any mets to the vertebra, that can also cause. Other than that, if it is intradural, it can be subarachnoiditis, or there can be a meningioma in the meninges around the spinal cord. Or if it is intramedullary, then it can be syringomyelia, or there also can be a tumor within the spinal cord like ependymoma.
Okay.
No.
So is my PPT visible?
Visible.
So shall I begin?
Go ahead. Yes.
Yeah, it's visible, but it's okay, fine.
So this is the case of a 52-year-old male from Jayanagar, Bangalore, who is a coolie by occupation and has studied till 10th standard. He belongs to the lower middle class according to Kuppuswamy classification. His informant was the wife, who was reliable. He is right-handed. He was admitted on the 8th of October 2021, and he was examined on the 11th of October 2021. He came with the chief complaints of weakness in right upper and lower limbs since 3 days, deviation of angle of mouth to the left since 3 days, and slurring of speech since 3 days. History of presenting illness. Patient was apparently normal 3 days ago when he developed acute onset weakness of right upper and lower limb at 4 a.m. after he had woken up from sleep. He was unable to hold a glass of water or lift his arm overhead. He also had difficulty in standing up from his bed and could not grip his slippers. Patient describes the weakness as equal in both the right upper limb and lower limb, which has been the same since he first noticed the weakness. Patient attenders noticed deviation of angle of mouth to the left side 3 days ago and not associated with drooling of saliva. Patient was able to close both his eyes. Patient had slurring of speech since 3 days, which was sudden in onset. He is able to comprehend words and follow simple instructions. He is also able to repeat sentences. Patient was taken to the hospital immediately following this.
Patient was recently diagnosed with hypertension and diabetes mellitus 1 month ago, for which he was prescribed medication but was not taking it regularly. There is no history of trauma or fever. There is no history of headache or vomiting, no history of loss of consciousness or seizures, no history of decreased sensations, and no history of any other cranial nerve involvement. There is no history of tremors and no history of chest pain or palpitation. Past history, the patient was diagnosed with hypertension and diabetes a month ago, not on regular medication. He was prescribed amlodipine and metformin. There is no history of similar complaints in the past, and there's no history of transient loss of consciousness or transient blurring of vision or loss of vision in the past. There's no history of epilepsy, tuberculosis, heart disease, or clotting disorders. Family history is not significant. Personal history, diet is mixed, appetite is normal, sleep is sound, bowel and bladder is normal. There's no history of smoking or alcohol intake, and there's no history of high-risk behavior. General physical examination. Middle-aged man is moderately built and nourished, is conscious and cooperative and well-oriented to time, place, and person. Vitals, his pulse is 71 beats per minute, regular, normal in volume and character. There's no radioradial delay and no radiofemoral delay. There's no thickening of vessel wall, and all peripheral pulses are felt. His respiratory rate was 16 cycles per minute, abdominothoracic type. His BP was 140 by 94 millimeters of mercury in the left brachial artery, and his temperature was 98.6 degrees Fahrenheit. His height was 160 centimeters, weight was 58 kgs, and BMI was 22.7 kg per meter square. Pallor, icterus, cyanosis, clubbing, lymphadenopathy, and pedal edema was not seen. There were no signs of atherosclerosis, and no neurocutaneous markers were seen. On higher mental function examination, he was a right-handed individual. He is conscious, cooperative, well-oriented to time, place, and person. Appearance and behavior is appropriate, and patient is emotionally stable. MMSE score was 26. Speech articulation was impaired. Speech output is normal. Comprehension is intact. Repetition is intact. Reading and writing is normal. Recent, immediate, and remote memory was also intact. On cranial nerve examination, everything was normal except for the facial nerve on the right. Forehead wrinkling was present. Ability to close eyes was present, but there was absence of nasolabial fold and inability to puff out cheek, and deviation of angle of mouth to the left was seen. Anterior two-third taste was present. And on the left, everything was normal, but deviation was seen on the left. On motor examination, the patient is in supine position with right shoulder adducted, flexion at right elbow, flexion at right wrist, and semi-pronated arm. Right lower limb is externally rotated with extension at hip and knee. There was no wasting seen. Tone was hypotonic in both the right upper limb and right lower limb. Power was 0 in both the right upper limb and right lower limb, and left was normal. Superficial reflexes, corneal and conjunctival reflex on both the right and left was present. Abdominal reflex was absent on the right, and there was an extensor response on the right for plantar reflex. There was diminished reflexes on the right. Sensory system examinations were intact on both the right and left. Cerebellar functions were normal. There were no signs of meningeal irritation. Examination of skull and spine is normal. On auscultation of the neck, there was no carotid bruit heard. Other systems, cardiovascular, S1, S2 heard, no murmurs and no carotid bruit. Respiratory system examination was normal with normal vesicular breath sounds heard and no added sounds present. And on abdominal examination, the abdomen was soft, non-tender, no organomegaly seen. To summarize, a middle-aged man recently diagnosed with hypertension and diabetes presented with right hemiplegia, right upper motor neuron lesion of the 7th cranial nerve since 3 days. On examination, patient has difficulty in articulation of speech, in neuronal shock with right upper and lower limb showing hypotonia, 0 power and decreased reflexes. No signs of any other cranial nerve, sensory or cerebellar involvement. Provisional diagnosis, he has a right hemiplegia and upper motor neuron lesion of the right 7th cranial nerve in neuronal shock, most likely involving the genu and posterior limb of the internal capsule due to cerebrovascular accident of thrombotic etiology.
Okay. Good, Mahima. Good presentation.
Thank you, sir.
Yeah. Now we have said it is a cerebrovascular accident. What made you think it's a cerebrovascular accident? What are the risk factors for this? What are the risk factors for this patient to develop cerebrovascular accident?
So the first thing is he has a history of hypertension and diabetes mellitus. He's
just very recent, 1 year, one month history as per your history.
But it could have been there for a longer period of time, but not detected.
Okay. How will you recognize the long-standing undetected hypertension? What are the clinical signs which will tell you that patient had long-standing hypertension?
On fundoscopy, you could see retinal.
Fundoscopy, you may not be. Yes, fundoscopy, you can get it. Hypertension. Anything else which you can detect? A clinical examination can detect.
Pulse can give you a hyperdynamic type.
Hyperdynamic. Anything else?
Other clinical effects of hypertension. What else will it affect? If you can examine.
So, end organ perfusion of different organs.
No, you have clinically examined CVS, which you have mentioned that S1, S2 normal. Now, what is the specific thing you need to look for in a hypertensive patient to find out whether it is a chronic hypertension, chronic untreated hypertension, recently controlled now, but he had a long-standing effect of uncontrolled hypertension? How do you recognize that? That is why each system is very important.
Yes, sir.
How do you recognize?
What is the cardiovascular effect of hypertension? What does it produce?
It's going to cause left ventricular hypertrophy.
So what are the clinical signs of LVH? What will be the clinical signs?
You will have it could cause pulmonary hypertension. Or S3, S4.
S4, correct.
Okay.
Then what will happen to the apex? Apex, what
the
is the
apex will be shifted down and out.
Character.
It'll be a heaving type of apex.
Okay. So you should have looked for that. Okay. You have looked for the carotid bruit, but you should also have looked for the chronic hypertension. Yeah. Yes. Why did you say it's a thrombotic stroke?
So because he gave a characteristic feature of wake-up stroke. He got up and he felt.
Okay. The exact event of timing of the thing is not known. Wake-up stroke is very usually a thrombotic stroke. Okay.
Yes, sir.
What is the arterial supply for this posteriorly, internal capsule?
So the lenticular striate branches of the middle cerebral artery.
Okay. Fine. What is Bell's phenomena? Did you look for Bell's phenomena in this patient?
Yes, sir. It's the upward rolling of the eyeball in element type of lesion.
Okay. Did you look for that in this patient?
No, sir, because wrinkling of the forehead was present and he was able to close his eyes completely.
Okay. Fine.
What are the risk factors for embolism? Common risk factors for embolism?
So mainly when it's embolic stroke, it's cardioembolism. So if vegetation's on the mitral valve in cases of RHD, or even if the patient has SLE, or even if the patient had recent history of MI, then he could have an embolism, atrial fibrillation in mitral stenosis, or it could be an atheroembolism from the carotid artery.
Atheroembolism from the carotid artery. That is more.
What investigation you do?
So when the patient just comes, the first thing to do is check blood glucose level and take a CT of the head. And after that, if to rule out hemorrhage.
Why do you want to do the CT? Why not MRI?
So because that rules out hemorrhagic stroke. Once that is done, immediately the patient can be put on alteplase for thrombolysis. Okay. And once that is done, you can take an MRI, or you can also do an MR angiogram.
Any other type of MRI which can pick up the infarct?
Diffusion weighted MRI.
Diffusion weighted images of the MRI.
Yes.
Correct.
Other investigations I would like to do are CBC, specifically looking for polycythemia vera or platelet count, and on blood glucose level, HbA1c, lipid profile, basic metabolic panel, chest X-ray, echo, ECG. Yes, sir.
Fine.
Anticoagulations in stroke. Do we anticoagulate patients with stroke?
It's usually not recommended unless they have a history of atrial fibrillation. You can put them on antiplatelets like aspirin or clopidogrel.
Any other indication for anticoagulation in a patient who has stroke? Atrial fibrillation is correct, as you said.
RHD, if they have a prosthetic valve.
That's all correct. That's a cardiac related. Other than that, just for the stroke, any anticoagulation do we give? Power is 0.
Hmm.
Power is 0. The entire limb power is 0.
I'm not sure, sir.
Can there be some complication that you can prevent?
Anticoagulation. I'm not sure, sir.
Sure. DVT prevention.
Yeah, yes, sir.
Okay.
Okay, fine. Thank you. Good.
Thank you, sir.
Next.
Yes, sir. Good afternoon, sir. I'm presenting the case of Mr. ABC, a 46-year-old male residing in Jasusar Gate, Bikaner, Rajasthan. He's painter by occupation and Hindu by religion. Date of admission was 17/9/2021 and date of examination was 18/9/2021. Chief complaint: patient presented with abdominal distension since 15 days and shortness of breath since 14 days. History of presenting illness: the patient was apparently normal 15 days back, then noticed generalized abdominal distension, insidious in onset, progressive in nature. Patient also noticed painless progressive swelling of lower limb since 10 days, which was also insidious in onset and progressive in nature. It was not associated with abdominal pain. There were no aggravating and relieving factors present. Patient also had shortness of breath since 14 days, which was insidious in onset, progressive in nature, and has progressed from breathlessness on exercise to walking relatively slower than the same age person. It aggravates on lying down and relieves on sitting. Negative history: there is no history of fever, chest pain, cough and expectoration, nausea and vomiting, clay-colored stools, blood-stained vomitus, IV drug intake, or tattooing. Past history: 3 years ago, patient complained of abdominal distension and pedal edema. 2 years back, he had an attack of shortness of breath along with fluid in abdomen, after which he was admitted to the hospital. In March, he was admitted again for altered consciousness, tremors, nausea, and vomiting. Several times paracentesis has been done. There is no history of tuberculosis, asthma, COPD. Family history: mother had complaints of tuberculosis 10 years back. No history of similar complaints seen. Personal history: he is vegetarian in diet, appetite is decreased, sleep adequate, bowel habits, patient is on lactulose, bladder habits normal and yellow discoloration of urine is seen. Alcohol: no intake, no smoking, no tobacco intake. Summary: my patient, Mr. ABC, is a known case of chronic liver disease and has presented with abdominal distension along with pedal edema 15 days and dyspnea 14 days. General physical examination: patient is middle-aged male. He is oriented to time, place, and person. Vitals: pulse 76 beats per minute. Rhythm normal, character regularly regular, volume normal, thickening of wall is normal, and no radial or no radiofemoral delay is present. Respiratory rates: 17 breaths per minute, BP 130/90 millimeter of mercury, temperature 98.5 degree Fahrenheit, height 175 centimeter, and weight is 95 kg. Icterus is present. There is no pallor, no cyanosis, no clubbing, and no lymphadenopathy present. Head to toe examination: hair normal, no alopecia, nose no polyp or mass seen, oral cavity no halitosis, no parotid swelling present. Nails were normal, skin black color, diffuse pigmentation seen on legs, no spider nevi, no palmar erythema, no flapping tremors. Axillary and pubic hairs were also normal. There was no gynecomastia and no testicular atrophy. Examination of abdomen: inspection: distended and elliptical, flanks were full, umbilicus was stretched, movement with respiration thoracoabdominal, dilated veins were not seen, there were no scars, and external genitalia was normal. Palpation: superficial, surface temperature 98.5 degree Fahrenheit, no guarding and rigidity was present, no tenderness, no cuff impulse at hernial orifices. Deep liver was not palpable, spleen not palpable, and kidneys were not palpable. On percussion, upper border of liver was percussed at 5th intercostal space. Shifting dullness was absent, but fluid thrill was present. Auscultation, bowel sounds were present. CVS, S1 and S2 clearly heard, no added sounds and murmurs present. Respiratory, trachea, midline, normal vesicular breath sounds present, no added sounds. CNS, no abnormality was detected. Higher mental functions normal. Motor and sensory functions were normal. Cranial nerves were normal. Provisional diagnosis. Patient is most probably having decompensated liver cirrhosis presenting with massive ascites. Thank you.
Okay. Okay. Fair presentation. Now there are some clarification I made. You have said decompensated liver cirrhosis. Is it a liver decompensated? You call it as decompensated liver cirrhosis or decompensated liver disease, chronic parenchymal liver disease. Anyway, it's okay with massive ascites. Okay. What is ascites precox?
So ascites precox is seen in chronic cardiac failure when there is ascites first, rapid ascites, rapid accumulation of fluid that is like reverse presentation of CHF. Like there's no pedal edema first, but there is ascites first and then pedal edema.
Which condition is it? Which condition?
So chronic cardiac failure.
Cardiac failure is CHF only, na?
Yeah, yes.
It has to be not like CHF, it should be something else. That is precox. Okay, fine.
You said the abdominal distension and breathlessness, which again occurred in 15 days and 14 days, 1 day difference. And you said insidious. Does it go hand in hand? No, don't go back. Don't go back. You said abdominal distension of 15 days duration, shortness of breathing for 14 days.
Yes.
And again, you explained that it is an insidious one. Do you call it as insidious one? Just 1 day difference from the development of abdominal distension to the breathlessness development. What are the mechanism of breathlessness in a patient who has got abdominal distension?
So if it is massive ascites, then diaphragm pushes the lungs up. That causes the
that's what I said. If it is a massive ascites developing over 1 day to produce breathlessness, do you call it insidious onset? No, okay. Or you don't call it as insidious onset and insidious progression, isn't it? Okay.
Any other cause? Any other mechanism how they become breathless?
Yes, hydrothorax can be there because of massive ascites that can lead to the breathlessness.
Okay.
You said if the patient is non-alcoholic, then what could be the reason for his chronic parenchymal liver disease, so-called CLD?
So it could be non-alcoholic, NaSH, non-alcoholic liver disease. So it could also be because of autoimmunity, and it can also be because of
most common cause other than alcohol, which is the common cause for cirrhosis.
So hepatitis.
Which hepatitis?
So hepatitis C.
Hepatitis C and
C and hepatitis.
Which one will produce chronic liver disease?
Yes, sir.
Hepatitis C and which is the other hepatitis which produces chronic?
So A.
Okay. No, okay. Now, did you mention anything about oliguria, hematuria, facial puffiness, anything? I didn't see that in the history. In a patient with the rapid development of abdominal distension, leg swelling, do you want to mention about urine output and urine hematuria, oliguria, facial puffiness? Those are all anticipated histories. Okay, fine. You also said something of black pigmentation in the lower limbs.
Yes,
very
sir.
specifically highlighted on the black. What are the causes of black pigmentation in the lower limbs?
Black pigmentation. So it can be a consequences of the chronic liver disease, which leads to pigmentation. And
why specifically to the legs only if it is liver disease? Okay. Now, did you mention anything about hepatic encephalopathy, symptoms of hepatic encephalopathy?
Yes, so he had an incidence of hepatic encephalopathy in the March.
No, currently?
Currently,
Not,
no, sir.
No. Okay. You also mentioned something which is, that is a surface temperature 98.5 degree. How did you record that?
Sir, I wrongly mentioned, sir. It was temperature.
Okay, you wrongly mentioned. Okay, doesn't matter. I just wanted to, I was curious about how did you mention the surface temperature?
No, sir.
You can't measure?
No, sir.
Can you measure?
Can you measure it?
So surface temperature.
Everywhere, everybody is measuring now. What they are measuring now.
So it's febrile and afebrile on touch.
Surface temperature, are we measuring now? Everywhere, everybody is measuring what now? With the pandemic, we're using surface temperature. That can be used for everything there, but it is not relevant. You don't write it in the exam like this. Okay.
Okay, fine. Done.
Fine.
Good. Okay. Next person.
All the best, Gayatri. Please start the presentation.
Yeah. Okay. Good evening, everyone. So my name is Gayatri, and I'll be presenting today's case. So these are general details of the patient. 52-year-old male patient, Mr. XYZ, who's a daily wage worker by occupation from Hassan, Karnataka, and belongs to middle class according to modified BGSGIMS classification, was admitted on 10th October 2021 and was examined on the same day. He came with chief complaints of distension of the abdomen since 6 months, swelling of both lower limbs since 2 months, yellowish discoloration of the eyes since 1 week. History of present illness, the patient was apparently all right prior to 6 months back, after which he started noticing a painless abdominal distension that was insidious in onset, gradually progressive, and diffuse in nature. It changes with position, and he also complains of associated abdominal discomfort. He also gives history of painless swelling of both lower limbs that was initially up to the ankle and gradually progressed up to his knees. It is present throughout the day and relieves on lying down or when his legs are raised. There's also a history of yellowish discoloration of eyes for the past 1 week that gradually progressed to the entire skin. However, there is no history of generalized itching or pale stools. He also gives history of difficulty in passing stools since 5 days and no history of associated abdominal pain or vomiting. There's also a history of excessive daytime sleepiness and decreased sleep at night since 3 days. There's no history of fever, myalgia, joint pain, rash, pigmentation, no history of any cough or breathlessness, orthopnea, PND, or platypnea, no history of facial puffiness or decreased urinary output, and no history of suggestive of hematemesis, melena, or bleeding per rectum. No history of any swelling in the neck, groin, or around the umbilicus. There's no history of easy bruisability, petechiae, and no history of significant weight loss. Coming to his past medical and surgical history, there's no history of jaundice in the past, no history of any recent injections, infusions, blood transfusions, IV drug abuse, tattooing, body piercing, or sharing of needles, no history of intake of herbal teas, etc. No recent travel history or exposure to contaminated food, exposure to occupational hepatotoxins, and no significant sexual history or high-risk behavior. There's no history of COVID-19 infection in the past, and he's not a known case of diabetes, hypertension, thyroid, bronchial asthma, TB, or seizure disorder. And there's no significant previous admission history or previous surgeries. There's no significant family history. Coming to his personal history, the patient consumes a mixed diet. However, his appetite has decreased since the past 2 months. There's difficulty in passing stool since 5 days and no associated blood in stools or abdominal pain. His bladder habits are, however, normal. He complains of sleeping more in the day and reduced sleep at night since the past 3 days. There's a history of alcohol abuse. So he's an alcohol dependent since 15 years and he stopped 4 months back. Consumes approximately 360 ml, that is 2 quarters of whiskey per day, which comes up to 14.4 units per day. There's no history of smoking or any other habits and no history of any known allergies. So coming to the summary, is a 52-year-old male patient, Mr. XYZ, who is a daily wage worker by occupation and an alcohol dependent since 15 years, presented with complaints of abdominal distension 6 months, bilateral pedal edema since 2 months, and yellowish discoloration of the eyes and skin since 1 week. So patient has ascites, pedal edema, and jaundice suggestive of decompensated chronic liver disease. Coming to general physical examination, the patient is conscious, cooperative, and well-oriented to time, place, and person at the time of examination. The patient looks moderately built and nourished, and BMI was not calculated as patient is suspected to have ascites. Coming to his vitals, his pulse rate was 76 beats per minute in the right radial artery, normal regular rhythm, volume, and character, no radial or radiofemoral delay, and no vessel wall thickening. His blood pressure was 110 by 70 millimeters mercury in the right arm on sitting position, and respiratory rate was 17 cycles per minute. Patient was afebrile at the time of examination. There's presence of pallor, icterus, and bilateral painless pitting pedal edema, grade 2. There's no cyanosis or lymphadenopathy and no raised JVP. Now coming to head-to-toe examination, the patient's face looks shrunken with sunken eyes and hollowed face and a pinched up nose with mala prominence and icteric sclera. There's also poor dental hygiene and bilateral parotid enlargement. Multiple spiral angiomas are present over the upper part of the chest and back. There's sparse chest and axillary hair, and gynecomastia is present. Clubbing of grade 2 is also present, and palmar erythema is present. Dipyridines contracture and asterixis were looked for and they were absent. No cyanosis or lymphadenopathy and no palpable thyromegaly. Coming to the alimentary system examination, his oral cavity, lips, and gums were normal. There's a yellowish discoloration of the tongues and palate, and dental hygiene appears poor. No fetal hepaticus and no angular cheilitis or glossitis. Coming to abdominal examination, on inspection, the abdomen is globular and distended, flanks are full, all quadrants move correspondingly with respiration. Umbilicus appears everted and shifted downwards, and visible tortuous dilated veins are present. There are no visible pulsations or no visible peristalsis, no visible swelling or mass, no scars and sinuses. Hernial orifices appear intact and external genitalia appear normal. Coming to palpation, inspectory findings were confirmed. No superficial tenderness, no guarding or rigidity, no deep tenderness. By dipping method, the liver is palpable 6 centimeters below the right costal margin along the midclavicular line. It is firm in consistency with a nodular surface and it is non-tender. Spleen is also palpable 6 centimeters from the left costal margin and the anterior axillary line towards the umbilicus, and notch is felt over the medial aspect. The surface is smooth and firm in consistency and it is non-tender. No other abnormal mass was palpable. Abdominal girth measures up to 105 centimeters and no testicular atrophy was noticed. Percussion, the upper border of liver dullness corresponds to the right fifth intercostal space along the midclavicular line, and lower border corresponds to 6 centimeters below the right costal margin along the midclavicular line. Liver span was 14 centimeters, and dullness over castle spot was noticed, and shifting dullness was present. Fluid thrill was absent. Paddle sign was not elicited. Auscultation, bowel sounds are heard, and venous hum was also heard. Per rectal examination was not done. Coming to systemic examination, CVS S1 and S2 were heard and no murmurs. Coming to respiratory system, normal vesicular breath sounds were heard and no added sounds. And CNS examination, there were no focal neurological deficits and no asterixes. So to summarize, a 52-year-old male patient, Mr. Ramesh from Karnataka, who's a daily wage worker by occupation and is an alcoholic dependent since 15 years, came with complaints of distension of abdomen since 6 months, and that increased progressively, and it is not associated with abdominal pain, but there is a sense of discomfort and feeling of fullness. He also has bilateral pitting pedal edema since 2 months and jaundice since 1 week. He has constipation since 5 days and altered sleep rhythm since the past 3 days. There is no history of fever, hematemesis, or melena, and in his personal history, he admits to used to consume 112 grams of alcohol since the past 15 years. No other significant past medical or surgical drug or family history. On general physical examination, he shows signs of liver failure, and on abdominal examination, there is presence of ascites and shifting dullness. Spleen is also palpable. So my provisional diagnosis is decompensated chronic liver parenchymal disease, most probably due to alcoholic dependency complicated by portal hypertension with encephalopathy.
Okay, good presentation, Gayatri.
Yeah.
Yeah. Now, what are the precipitating factors for the hepatic encephalopathy?
Sorry?
What are the precipitating factors for the hepatic encephalopathy?
The precipitating factors could be constipation itself, because that can cause accumulation of the toxins. Then apart from that, GI bleeding. Then
because in your patient, he was having features of chronic liver failure and ascites for more than 6 months.
Yeah.
Now, only from the past 3 days, he has got altered sleep rhythm.
Yeah.
Isn't it?
Yeah.
So
Yes,
that indicates hepatic encephalopathy. You
Yes,
have
sir.
already mentioned that. So what are the common precipitating factors you need to look for?
Upper GI bleeding. internal.
Other than that,
Yeah.
Other than bleed and constipation, what are the other common things? Can worsen the encephalopathy, very common. He's on some medications which can cause something.
Medication.
What medication? Okay, in ascites, what is the common medication you give?
Medications.
Diuretics.
So what can happen?
Diuretics.
Okay, if you do not know, it's okay. So,
you said some curvilier Baumgarten murmur is
yes,
you
sir.
could hear.
Yes, sir. Venous hum.
Where did you hear it and what is the relevance?
You hear
where did you get, which part did you auscultate?
Around the umbilicus.
Around?
Over the
or above the umbilicus?
Above the umbilicus.
Right
above
side or left side? The right side or left side?
Right side.
What does it indicate? Why do you get a hum there?
It suggests portocaval anastomosis, so portal hypertension.
Anything more specific?
Shunting of the blood.
Is anastomosis only a particular vein it indicates?
Anterior umbilical vein.
Obliterated, something obliterated. Some embryological thing which opens up.
Ductus sinuus.
Okay. Now you said about the edema.
Yes, sir.
Okay. Was it a fast edema or slow edema? What do you understand by fast edema and slow edema?
It's a fast edema because it
Not
depends
because
on
in this patient.
Yes, sir. It's a fast edema.
Okay. Okay. What are the causes of tender ascites?
Tender ascites can be due to spontaneous bacterial peritonitis, secondary peritonitis, then obstruction, intestinal obstruction.
Any other organ? Any other organ involvement which can cause tenderness and ascites?
Hepatitis.
Hepatitis. Alcoholic. Any other organ is there which can get involved? Painful ascites.
Due to tricuspid regurgitation.
No.
Congestive
hepatomegaly. Other than liver, which is the other organ involved in acute?
Spleen.
Acute condition.
In between two things.
The stomach.
Behind stomach.
No. Something behind it.
Spleen.
Acutely, patient can come with the acute pain.
Oh, acute pancreatitis.
Acute pancreatitis.
Yes, sir.
How did you palpate for the spleen in such a massive ascites patient? What was the picture of your patient or the copied picture?
No, sir. It's
Indicate
not.
Picture.
It's not my picture.
Okay, fine. So, how did you palpate for the spleen, or how do you palpate for a spleen in a patient who has got massive ascites?
You can palpate by Nixon's method.
Nixon's method palpation. Okay. Any specific
palpation? Palpation is those are.
Sorry, sir. By
Nixon's and all is percussion method.
By
palpation is
dipping method.
Dipping method.
Fine. Why did you look for Pudel's sign in this patient who has got a massive ascites?
Actually, you don't need to look for Pudel's sign.
Then why did you mention that?
By mistake, sir.
Okay. What are the mechanism of gynecomastia in this patient or any CLA patient?
Alteration in the androgen to estrogen ratio. So because of that, the estrogen production increases and features of hyperestrogenism. So gynecomastia is a feature.
Any other cause? Any other cause in this patient can cause gynecomastia?
Diuretics also. Spironolactone. Spironolactone can cause gynecomastia.
Okay. Any investigation, anything, Archit, procedures?
Okay.
Investigations. What investigation in a patient who has got a umbilical bruit? What investigation would you like to do? Splenomegaly and other things. What specific investigation would you like to do?
Ultrasound abdomen, Doppler flow. Doppler flow.
You said there is a splenomegaly, large splenomegaly, and there is a dilated veins and bruits. Everything is there.
Yes, sir.
So what do you anticipate? What complication do you anticipate now?
Complication they can have.
Portal hypertension.
As a sequence of that, what can they develop? Which you should be worried about. You have to do one more investigation. Look into
invasive one. To prevent his catastrophic event. Further
paracentesis.
No. Not paracentesis.
Have you heard of upper GI endoscopy?
Yes, sir, upper GI endoscopy.
No, why?
To look for bleeding varices.
Or impending bleeding. If it was impending bleeding, you need to ligate it. So
like endoscopic band ligation.
Okay. Fine.
Thank you, sir.
You can start presentation.
Yeah, they start.
Good evening, everyone. My name is Riddhi Soni. My patient, Mr. XYZ, a 42-year-old male, a watchman by occupation, resident of Kamothi, Navi Mumbai, was admitted on the date of 4th of October 2021. He presented with the chief complaints of distension of abdomen since 4 months, swelling of the lower limb since 3 months, and vomiting of blood since 2 days. My patient was apparently all right 4 months back when he noticed distension of abdomen with the pants becoming tight over the abdomen, which was insidious in nature, gradually progressive to current state. It was painless with no aggravating or relieving factors. He also experienced swelling of his lower legs since 3 months, which was insidious in onset, which gradually progressed from the ankle to below the knee, which was relieved on lying down. He experienced vomiting of blood since the last 2 days, which was sudden in onset, non-projectile, bright red in color, and 20 ml in quantity. Negative history. There was no history of abdominal pain, dyspnea, puffiness of face, fever, melena, hematochezia, weight loss, reduced in urine output, orthodeoxyplatypnea, orthopnea, paradoximal nocturnal dyspnea or chest pain, or constipation, disturbed sleep, abnormal movements, Kayser-Fleischer ring on cornea, skin hyperpigmentation, emphysema or COPD, or xanthalasemia. There was no past history of hypertension, diabetes, mellitus, tuberculosis, or asthma, or any blood transfusion, tattooing, or chronic drug intake, or any abdominal surgeries. Personal history. He consumes a mixed diet. His appetite is reduced. Sleep is undisturbed. Bowel and bladder regular. Habits: consumption of 180 ml of whiskey daily since 8 years and denies smoking. There's no apparent drug history. No similar family history. To summarize, a 42-year-old male with significant alcohol consumption since 8 years comes with a complaint of abdominal distension since 4 months, edema in lower limb since 3 months, and hematemesis since 2 days. My probable diagnosis of the disease is cirrhosis of liver with ascites and portal hypertension. General examination. The patient is a middle-aged man, moderately built, undernourished and afebrile. He is conscious and cooperative and well-oriented in time, place, and person. His vitals: pulse 80 beats per minute with regular rhythm, normal volume, force and tension, no radio-radial delay or no radio-femoral delay. All other peripheral pulses felt bilaterally. The blood pressure is 110 by 70 mm of mercury in the right arm in supine position. The respiratory rate is 20 cycles per minute. GVP not traced. Temperature afebrile measured in the axilla. BMI not calculated since the patient had ascites. Pallor absent, icterus absent, clubbing present, grade 2. Stenosis absent, lymphadenopathy absent, and edema was pitting type present in the lower limbs. Head to toe examination: no scanty hair, no angular stomatitis or cheilitis, parotid swelling present, spider nevi absent, no gynecomastia, testicular atrophy or loss of libido, Dupuytren's contracture, flaps and palmar arrhythmia absent, fetor hepaticus absent, scar sinuses in neck, lymphadenopathy, pleura petechiae absent, and no significant changes in the knees. Elementary canal examination. The examination of the oral cavity. The teeth had normal dentition, tonsils not enlarged or red, tongue normal, oropharynx normal. My patient is exposed from xiphisternum to pubic symphysis in supine position. There is generalized distension of abdomen with maximum fullness in the flanks. Umbilicus is everted. The distance between the xiphisternum and the umbilicus is greater in the distance between the umbilicus and the symphysis pubis. No fluid is exuded from the umbilicus. The abdominal movements are normal, bulges during inspiration and falls during expiration. No abnormal pulsations. No dilated veins are seen around the umbilicus with blood flow away from umbilicus, confirmed by the Harvey sign. Skin over the abdomen is smooth, glossy. It has no scars or abdomen. Peristalsis movement are normal. No divarication of recti. Hernial orifices and external genitalia appear normal. No hernial abdominal girth 106 centimeter. Zippy sternum to umbilicus 36 centimeter. Umbilicus to symphysis pubic 26 centimeter. Umbilicus to anterior superior iliac spine on the right side is 36 centimeter and on the left side 36 centimeter. This is the picture of the patient. Palpation, the patient is made to lie down in supine position with hip and shoulder slightly raised and the knees are flexed to relax the abdominal muscles. Superficial palpation, there is no tenderness or local rise of temperature, no guarding, no rigidity. On deep palpation, the liver is palpable 5 cm below the right costal margin at right mid-clavicular line, firm in consistency, sharp and irregular nodular margin. Surface is irregular and is non-tender by dipping method. The liver span is 14 cm. The spleen is palpable 5 cm below the left costal margin in anterior axillary line towards the umbilicus. Surface is smooth, firm in consistency, non-tender. Kidney is not non-palpable, gallbladder not palpable, fluid thrill is absent. On percussion, horseshoe-shaped dullness present, shifting dullness present, spleen, Chauvet space, tympanic note heard. Auscultation, normal peristaltic sounds are heard, no venous hum or bruit, no friction rub, no succussion splash. Other systems, the cardiovascular system, S1 and S2 sound heard, no murmurs heard. Respiratory system, normal vesicular breath sounds heard, no agate sound. Central nervous system, higher mental functions normal, no flapping tremor. For rectal examination inspection, there were no fistula tracts, excoriation of skin or ulcers. On palpation, no ulcer, mass and tenderness. The scrotum, there was no hydrocele or hernia or testicular atrophy. Spine was normal and supraclavicular fossa normal. My provisional diagnosis for my patient is decompensated parenchymal liver disease due to alcohol consumption with ascites and portal hypertension. Thank you.
Yeah, good presentation. You go back to one slide, please. Your provisional diagnosis slide. Oh, okay. Yeah, no, provisional diagnosis slide. Yes. That's enough. These are short things, no? Yeah. Okay, now there are some things. Why did you do the rectal examination? Is it mandatory to do the rectal examination?
Sir, because the patient had hematemesis, I felt it was necessary to know if there were any fissures or because there is portovenous anastomosis in the upper anal canal by the superior rectal vein and the middle and inferior rectal vein. So to see if there was any bleeding or if that was affected.
PR can find out that?
How will you see the veins? What will you do to see the veins?
Sorry, sir?
What will you do to see those veins, superior rectal or something? Can you see
engorged rectal veins? How do you see?
How do
Just
you
by
see
doing
that?
PR, you'll not be able to see that, no?
You can't see. No? It's inside. No?
What scope you will do?
What scope you will do?
Proctoscopy.
Proctoscopy. So PR only you can see the color of the stool. If you want to look for the melena or the frank blood, you can look for the PR. Okay. Otherwise, it is not this thing. Now, what is the significance of abdominal measurement? You are mentioning about some measurement, isn't it?
Yes, sir.
What are the significance of that?
So the distance between xiphisternum and umbilicus increases if there is any ascitic fluid, but the distance between umbilicus and the pubic symphysis increases if there is any ovarian mass or ovarian tumor, any other tumor in the lower in the abdomen. So that
what else will help you to find out whether it is a loculated cyst or loculated effusion or free fluid?
Shifting dullness.
Okay.
So there are no dilated veins, na?
Yes, sir.
But then you said it has been confirmed by direction of flow. When there are no dilated veins, how can you do the direction of flow?
Like the normal direction of the flow was from.
True, but then you didn't see any veins. Na?
No, sir.
Then once there is no veins visible, you can't check the direction. So don't write that you confirmed the direction of veins which you could not see. What's a normal flow? What's a normal direction of flow?
From away from the umbilicus.
What happens in portal hypertension?
Portal hypertension, if there is inferior vena cava obstruction, then
portal hypertension. In portal hypertension, what will be the flow?
Towards the umbilicus.
No. Portal hypertension, the flow is
away only.
Normal, away from the umbilicus.
Yes.
Yes.
You had also mentioned something about loss of libido in the examination.
Yeah, in the examination.
No, I meant no loss of libido because
that cannot be an examination.
It is not a part of examination. That is the history, isn't it?
Yes.
You cannot test the libido on examination. Okay, there's one more thing. Yeah.
First thing she said, I think, no loss of hair or something. First thing on no hair. Yeah. That means there is no hair or?
No, like no alopecia, sir.
So that should have been no alopecia, no hair, something. So that's also.
Now, your patient had upper GI bleed, isn't it? Yes. Hemiplegia.
Yes,
and you said blood pressure is normal, but you should have looked for something else, no? In a patient with recent GI bleed to find out what do you anticipate in the GI bleed? Intravascular volume.
What do you expect?
I didn't get the question.
What do you expect the blood pressure when there is a recent bleed?
To be low, like to decrease.
Specifically, you will do something. You said the BP when you checked was normal.
Yes.
So how will you know whether anything else you can do? Check the blood pressure in some other way.
Check the blood.
What is significant postural hypotension?
To make the patient lie down and check the the blood pressure values.
Then
after that, what do you do? Lying down blood pressure and postural, na? What posture?
In the recumbent position, you have to check the blood pressure value.
Any time gap? What is the significance? How much drop you anticipate in a postural patient with a postural hypotension?
Three values are taken at a three, and then the average of those three values is.
What will happen to the pulse rate?
If there's after the blood loss, there will be a drop in the pulse rate as well as the BP.
Pulse rate will drop. Okay, fine. So okay.
BP will drop.
There will be postural hypotension, but there will be postural tachycardia. It will go up. So in a patient with a hematemesis, you should look for that. Okay, that is a clue. So to find out the effective intravascular volume depletion, other things. Okay.
What are the causes for hematemesis other than varices? Can you tell some causes of hematemesis other than varices?
Any peptic ulcer, GERD, any tumor, peptic stomach carcinoma, Mallory syndrome.
How do you elicit the history of Mallory syndrome? What would be the typical history of Mallory syndrome? You can differentiate by history itself.
How does the bleeding happen? What is Mallory's? Then you will know.
Not sure how to differentiate, sir.
Okay. What is Mallory's there? Any idea? Yeah, it's okay. It's okay. And in the history, at the end of the history, you said decompensated cirrhosis. I mean, something about cirrhosis.
Decompensated parenchymal liver disease.
It is always, you should always mention cirrhosis is always a chronic parenchymal liver disease.
Yes.
Acute decompensation. What other complication? I think in the final provisional diagnosis, you should also mention about no evidence of hepatic encephalopathy. You should have also added that.
Okay, sir.
Okay, fine. I think other questions we have already discussed. What is your approach? What complication you anticipate now?
Complications could be hepatic encephalopathy. It could be hepatic cellular carcinoma, hepatorenal syndrome, hepatopulmonary syndrome. If there's any infection because of the rupture of the varices, that could lead to subacute bacterial peritonitis.
Now, this patient with the upper GI bleed, how do you manage?
So to manage, you can do it either pharmacologically or you can do the surgical approach. So pharmacologically, you can give vasopressin, which is a vasoconstrictor, terlipressin, which is a synthetic analog of vasopressin.
What is the maximum dose? Up to what will you monitor when you give this vasopressin or Or vasopressin?
The usual side
How to
effects
titrate?
are vasopressin is 0.1 mg.
How do you titrate clinically?
What are you looking for?
Any cardiac arrhythmia or myocardial infarction or angina shouldn't be precipitated.
No, you will wait till the development of the myocardial infarction or arrhythmia. What is the monitor?
Chest pain.
Chest pain.
Chest pain.
Yeah.
Yeah, you can start.
Yeah, go ahead.
Okay.
Good evening, sir.
Ashay, you can start the presentation.
I'm presenting the clinical. Yes, sir. Coming to the patient details, name XYZ, aged 50 years male, who comes from Kortagere, who's a school teacher by occupation, with the informant being the wife, which is who is a reliable source, comes with the chief complaints of sudden weakness of the right upper limb and the lower limb since 3 days and inability to speak since 3 days. History of presenting illness. A left-handed gentleman was apparently normal in his usual state of health, performing his routine daily activities until 3 days back. On October 2nd, 2021, when the patient had a fall at 4:30 a.m. while attempting to get up from the bed, on measuring his GRBS, the glucose levels, it showed 89 mg/%, following which he also noticed weakness in his lower and the upper limbs while doing his activities like raising his arm, holding objects, needing support to walk, and gripping his slippers. He also noticed the inability to speak, however, was able to understand what the wife used to tell. There is no history of headache, nausea, vomiting, aura, fever, weight loss, history of head or spine injury, involuntary abnormal movements, uprolling of eyeballs, no history of urinary incontinence, no history of loss of consciousness, palpitations, breathlessness, or any previous dental procedures. Also, there is no history of tremors, blurring vision, double vision, drooling of saliva, difficulty of chewing food, deviation of angle of mouth. As described by the wife, the patient was brought to the emergency room on the same day at around 10 a.m. Past history. He is a known case of diabetes mellitus type 2 since 5 years and on regular oral hypoglycemic agents, glycomet CR. He is a known case of hypertension since 5 years on medications, amlodipine 5 mg. There is no history of similar complaints in the past, rheumatic heart disease, ischemic heart disease, tuberculosis, asthma, seizure disorder, or any previous dental surgeries. Family history, there is nothing significant and contributory like a family history of migraine or any familiar cardiovascular diseases. Personal history, he has a mixed diet, undisturbed sleep, normal and regular bladder and bowel habits. He is a reformed smoker, 2 packs of cigarettes per day since 15 years, denies any alcohol consumption. Summary. This elderly gentleman, who is a reformed smoker, diabetic and hypertensive, on regular oral medications, presented with weakness of upper limb and right lower limb, which has been non-progressive since the admission, who also has an associated motor aphasia. He does not have any symptoms suggestive of any brainstem, cranial nerve, sensory, bowel or bladder, or cerebellar involvement. I consider him to be having a right hemiparesis involving the MCA territory, probably due to a thrombotic occlusion. Sir, next slide.
Go ahead.
Examination. Date of examination 5/10/21 at 8 a.m. Handedness, left hand. Patient lying supine on the bed, comfortable. He was conscious, cooperative, obeying commands, oriented to time, place, person, normal spine and cranium. There was no pallor, icterus, clubbing, cyanosis, lymphadenopathy, edema. Moderately built and nourished with a BMI of 23.2 kg per meter square. With he having a blood pressure of 148/70 millimeters of mercury, which was measured on the right arm in supine posture. pulse rate being 78 beats per minute, regular rhythm, normal volume and character, with the arterial wall not thickened. Peripheral pulses were felt with equal intensities bilaterally, with no radio-radial or a radio-femoral delay. Respiratory rate with 20 cycles per minute, abdominothoracic type, normal pattern with the normal pattern and depth with no use of accessory muscles of respiration. Central nervous system examination, higher mental functions. The patient was conscious, alert, cooperative, with the immediate, recent, and remote memory intact. He had a spontaneous speech with absent repetition, naming, and reading. Comprehension was preserved. He was able to identify the left and right side of his body. Cranial nerve examination. All the cranial nerves were intact bilaterally. Motor examination. There was in the both upper in motor examination, the tone in the both upper limb and the lower limb, flexor and the extensor on the right side, the tone was reduced. Impression saying the hypotonia on the right side. Power, there was power of at the shoulder joint, it was 3+, elbow joint 2+, wrist joint 3+, hip joint 4+, knee joint 3+, ankle joint 3+. Impression saying there was reduced power in the right upper limb and the lower limb with flexors greater than the extensors. Reflexes. Speaking about the deep reflexes, they were normal on the left side, and on the right side the jerks were absent. Superficial reflexes, there was absent abdominal reflex on the right side and a extensor reflex on the right side. Extensor plantar, upgoing plantar was present. Impression, deep reflexes are absent on the right side with abdominal reflex lost on the right side and an upgoing plantar. Sensory system, no sensory deficits were noted bilaterally. Cerebellar functions, no signs of cerebellar dysfunctions were present. Other systemic examination, cardiovascular examination, S1, S2 heard normally in both the areas with a normal S2 split. There was absent carotid bruit and no murmurs were heard. Respiratory examination, chest movements with with movements equally bilaterally with normal vesicular breath sounds with bilateral equal air entry and no added sounds were present. Per abdomen, soft, non-tender abdomen with no palpable organomegaly. Diagnosis, right-sided hemiparesis with upper limb more involved than the lower limb, suggesting of brachial dominant hemiparesis with Broca's aphasia and no cranial nerve, sensory or cerebellar involvement. The probable anatomical structure being involved might be the superior division of the left middle cerebral artery and etiology being a thrombotic occlusion. Yes.
Yeah, good presentation. Now, you said something about speech. Which type of speech is it? You already mentioned it is Broca's.
Yes, sir.
What makes it a Broca's aphasia?
Yes, sir. Sir, since he is able to comprehend the things what we are able to, what we ask him or what the wife is able to tell him as according to the history. Since the comprehension is in, yes, sir. The fluency is absent, sir. Fluency, naming, repetition, all these things are absent, sir. So that's.
No, you said the repetition is absent. That's what I'm asking. What is the significance of repetition in this motor aphasia? It may not be appropriate for you, but still, because you have mentioned repetition, I'm just asking. Repetition is absent.
Sir, since it's one of the components of. Sorry, sir.
He's not able to speak itself. He's not able to speak, isn't it? Fluency
Yes, sir.
itself
He's
is
not able to
affected.
speak, sir.
Then will the repetition be there? Will he be able to repeat when he's not
Sir,
able to
like,
produce word?
No, sir. He won't be able to repeat. Like, since like it comes under as a part of speech. I just mentioned it, sir.
No, I do agree that there is something called as motor aphasia, but in the two forms, one is Broca's aphasia and one is transcortical motor aphasia. Okay, so when speech is, repetition is specifically lost, you don't call it as a Broca's aphasia, you call it as transcortical motor aphasia. Okay, fine. It's okay. Doesn't matter. At your level, it's fine. No issue. If you say motor aphasia, it's good. Okay, fine.
Yes, you said your patient is left-handed. Huh?
Yes.
The first thing you mentioned was this patient is left-handed.
Yes, sir. Yes, sir.
What's the importance? What is the importance of this patient being left-handed?
Sir, generally it's that the person's right half of the body functions are controlled by the left hemisphere, and the left functions of the body are controlled by the right hemisphere.
You call it by
but
dominant
in
hemisphere.
Left-handed individuals also, like about 60%. Sorry, sir.
Yeah,
go ahead.
Continue. You're saying something. Continue.
But in about even 60% of the patients, there will be a dominant hemisphere of the left side, sir. In left-handed individuals, around 60% of the people will have a left dominant hemisphere. But since our patient is not able to speak properly, we can consider him to have a this. Like,
which cortex has got involved in your patient? Which side cortex
the
has
left
got
cortex
involved?
only, sir.
Left
Because
cortex only has got involved.
Left cortex only, sir. Because
correct. So despite
why did you mention? Why did you mention history of?
That left cortex is dominant. That's what it means. Okay, sir.
Why did you mention about the history of checking the blood sugar level?
Sir, he's a known case of the diabetes, sir. So in the early morning, like as soon as he fell out of the bed, probably like first thing what they would think was to check their blood sugar levels, because maybe they would have gone down or something.
Okay,
so
non-diabetic.
So that's what they had provided us with.
Non-diabetic on self-monitoring of blood glucose level. Okay. Now you also mentioned about nausea and vomiting. What is significant with nausea and vomiting with the onset of stroke? Nausea.
Sir. Yes, sir. Like probably like to rule out if there was any hemiplegic migraine, sir. Like migraine just will be having nausea or.
Okay. Any other thing? A patient has got hemiplegia, suddenly has got headache and vomiting, projectile vomiting without nausea. What is significance?
Sir. Okay, sir. Without nausea means the patient could have a raised intracranial tension, sir, with blurring of vision.
What are the warning signs?
Or the patient can present. Yes, sir.
There's one more thing you mentioned is you mentioned every symptom from 4 a.m. to the onset till 10 a.m. What happened after that till your examination? What are the progression of the symptoms?
Sir, I had mentioned, sir, it's like it was a non-progressive type of symptom. Like the symptom in progress, sir. However it was in the beginning, it was the same at the time of examination.
Any significance for that?
Generally, the thrombotic strokes are.
Neither worsened, it did not improve. So, what would have improved? Which, if supposedly by the evening it would have completely improved. What is its relevance?
Suppose it would have. Suppose the patient would have improved by within 24 hours, the maximum time of 24 hours. It could be a transient ischemic attack, sir. But since since it's not improving, it could be a hemiparesis.
Okay.
What are the other
you also mentioned,
mimics of stroke? Mimics.
Sir, one is Todd's palsy, sir. Todd's palsy is after an episode of seizures, where due to a neuronal exhaustion, there will be flaccidity of all the muscles, so that will mimic. Other one is like if another mimicker is hemiplegic migraine. Other one could be like if patient malingering, that could also be one of the.
Okay. How do you differentiate malingering clinically?
Sir, yes, sir. By giving any sudden reflexes, like by throwing an object suddenly to the patient like that.
Any maneuvers you know?
Painful
What is Boas maneuver?
No, sir, I'm not sure.
No issue. You also mentioned about BMI. How did you measure BMI in this hemiplegic patient?
Sir, they knew, sir, the patient attendants knew the weight and height. So like they gave average height and weight. So based on
it
that,
is the BMI is not average. It is you should be very,
it's an
very
average BMI.
Okay, you should not approximation. So you should be extra cautious.
Okay, sir.
You also mentioned that patient is reformed smoker for 15 years. What did you mean by that? What was your understanding of reformed smoker?
Sir, reformed smoker in the sense he quit smoking after like he was a known smoker since 15 years. He quit smoking about 8 to 10 months after that. That's all, sir.
Okay. So you just mentioned reformed smoker. What was the duration of reforming? You did not mention, I believe. Okay, anyway.
When we add up the both of your scores, please some concluding remarks by both Archit sir and Sir Bhatt sir, please. For the students,
that's what I said. The students have all the participants have done extremely well. They have presented the cases very well as per the protocol. They have presented very well. I assume I noted some of the things they have. What is that? Without doing proper examination, sometimes they have added for the completion's sake. That's what I noted in some of the things. But you need to be honest in your presentation. Whenever you do not know, whenever you are not done test, you have to agree that you should be agreeable or commit that you have not done that examination. Simply for the sake of presentation, do not commit the falsifications. Okay. Otherwise, all have done the extremely well on the part of the history presentation as well as the examination part. Discussion, of course, it varies. It varies depending upon the knowledge and depending on the experience. It may vary, but anyway, it's a good effort by everyone. All kind of cases have been presented. Good. That's from my side.
This video, the 3 hours of video, this would be more than sufficient for any exam going student. If he watches these videos and goes for the exam as a revision, I'm telling, after reading the books.
Not only after reading the book, after examining the multiple patients, it will not be enough for a first-timer person who comes and listen to this video. May not be enough. They should know how to take the case, how to examine the methodical examine the patient. That is not bypass. That cannot be bypassed. It's only for the discussion part, facing the viva, how to present. Yes, I do agree.
Yes, sir.
They have to examine
the template of the case sheets which they have written, history format and all. That can be very much useful. But
yes, very.
You have the history format. What all of you have written is wonderful. History, the various points you have covered, very nice. All the history templates can be used, but the examination has to be particular to your case that you get, and that has to be only practiced. So all of you have written the findings, but you have to write. Not necessarily that every heading has to be covered. And it's practically not possible when you do in your exam for 1 hour that you can do every examination. Okay, you can say that you have not done it, it is fine. But you should know what is the relevance of each of the examinations. What is the relevance of the nervous system in GIT? What is the relevance of the nervous system in a cardiovascular? Such things you should be able to infer. And not just the findings, the interpretation of the findings also is very important. And some basic signs like blood pressure and all, you should be very, very clear how the blood pressure will be affected in various things. And I think everybody who has presented very well and confidently, and more reading and more presentations will obviously improve that. The case history template, you can use this history template. The examination has to be done.
Yeah, exactly. Now something is added to the new knowledge. Yeah.
Yes.
Something is better than nothing. So we are doing good.
Yes.
All right. Thank you, Kishan.
Sir, 1 second. We are ready with the results. Meanwhile, I would like to say everyone have done really well because you are the finalists. Equally good. So, and there was very type of presentation we could see from the different part of our country as per whatever you all learned in your colleges. But most of them all over, like all over, all of you are present really well. Only there's a difference of slight 1 or 2 marks difference. But today we have got the very sweet, very lenient professors today. In your exam, it will not be so. Okay, that's for sure. As per their markings today, I would announce top 5 positions. In the 5th position, we have Mr. Ritvik. Mr. Ritvik is from High Tech Medical College, Bhubaneswar. Is in the 5th position. And in 4th position, we have Mr. Sai Ashray from Siddhartha Medical College, Tumkur, in 4th position. In the 3rd position, actually, there is only 0.5 difference between 3rd and 2nd. 3rd position is backed by Miss Mahima, 4th year Mbbs from BMC Bangalore. 2nd position is by Mr. Keshav Garg from MAMC Delhi. And in the 1st position is Miss Neha, again from BMCRI Bangalore. So congratulations to top 3. You'll be receiving a cash prize soon. And all the other finalists will be getting the e-certificates as well. And thank you so much for our mentors and judges for the day, Professor C.R. Bhatt sir and Archit Bolur sir, for detail, all the students. Nobody will take this much of efforts to help the students on this, especially on a Sunday afternoon like this. You are always with us to help, always help us, supported us, and we need blessings throughout, sir. And all the students also put your best efforts. And yeah, just like sir mentioned now, for just for revision, you can watch this. For last minute revision, you can watch these and depend on these videos. But these are also not substitutes for bedside clinical examinations or reading from the textbooks. These are only to gain the confidence after the all reading for revision sake. Once again, congratulations to all the participants, and once again, thank all the viewers and the members of White Army.